Good morning. Welcome to AIG Hospitals. This is the one of its kind live transmission that we are having this morning, showcasing some emerging technologies that are used in minimally invasive surgery. We are all aware of the imaging modalities that have changed from the time that minimally invasive surgery has started. We had this analog cameras, analog monitors, then we switched on to high definition monitors, high definition telescopes. And then subsequently, what happened was the industry started using different types of technology, started using enhancing the colors which are currently available, the current available 7 colors. They started augmenting the colors, they starting filtering the colors and started selectively taking some colors to improve the visibility on the monitors, which would enable minimally invasive surgeons to take laparoscopy to newer heights. As a part of this, actually, Olympus has introduced a new imaging system, a new imaging platform, which is called as Visera Elite 3, which integrates the 4K, which integrates the ICG, and also they have a new technology called as yellow enhancement, which enhances the yellow light, which is able to help in differentiating the vascular structures, the fatty structures. So this is making life comfortable for the laparoscopic surgeons. But basically, all this is in infancy. Basically, we started this because there is so much of enthusiasm across the globe that now we have an International Society of Fluorescein Guided Surgery. The entire meeting today is being done and is being endorsed by the International Society, which is the International Society for Fluorescein Guided Surgery. We thank Olympus for giving us this opportunity to use this system for the first ever time. We have done this live transmission before. But this entire concept of this meeting is not to showcase the techniques of the procedures, but to see how ICG and the yellow enhancement are useful in current day clinical practice. That is the basic crux of the thing, and then we are not concentrating basically on the techniques of the procedures. We have lined up a couple of cases just to show the difference between white light and the yellow enhancement and also how ICG is used. It has become a standard of practice in most of the minimally invasive centers to use ICG as a part of the thing to check for the vascularity of the bowel and also to check for the lymph nodal clearance. So though this is considered very, very safe, actually, we have our anesthetic colleagues who help us administer this during the procedure as and when we require. Multiple times it can be injected. Actually we'll listen from their perspective as to what the difficulties they face. And subsequently, I'll hand over my mic to Dr. Sanjeev Patil, Dr. Rohit and Dr. Ash, who will be performing the procedures. And also I thank on the other side, actually, Dr. Pradeep, Dr. Biju Potakat is there, actually, Dr. Rajesh is there, and Rohin Mittal is there, who are expert minimally invasive surgeons. We all know that you are experts in this field. We just wanted your opinion regarding this. It is not that we are saying that this is the best. This entire meeting is scheduled to see how this can help, how this can be improved, how we can improve the results on this to improve the outcomes of minimally invasive surgery. So before we go on to this, actually, I'll hand over my mic to our senior anesthesia colleague, Dr. Lakshmi, who will tell you the basics of ICG and how they administer this thing and what are the pitfalls of administering this and how much of dosage they can administer and whether they encounter any reactions. And subsequently, we'll hand it over to Dr. Sanjeev, who will be running through a procedure to show you the concept of white light, the yellow enhancement and the ICG. Thank you so much once again for joining us. And by the way, actually, I just have to tell you that Olympus has done an incredible job. We have over 350 people who have registered for this meeting, not just in India, across the globe. So we have people who are watching us from Asia Pacific region, from the Europe and the Americas. Olympus has, Japan has made sure that this transmission is going to all the Olympus centers across the world. Thank you so much, Olympus, for doing this incredible job. Dr. Lakshmi, please.
Good morning, one and all. And we are here to have a couple brief about how anesthesia department is involved, anesthesia colleagues are involved in administration of ICG for a better and a safer outcome. And briefly, why ICG is preferred over the fluorescein dyes is very important to know, because it has lesser adverse effects and also better penetration and a slow diffusion. So the ICG is usually available in the powder form. It's 25 milligrams, and it's diluted with the distilled water into 5 cc. That leads to 5 milligrams per cc concentration. And also you need to administer it with a filter, which is included with the kit that comes with it, and it's a 0.2 micron filter. And you need to be very careful while we are administering it, because we need to make sure that it doesn't extravasate, and also any history of previous dye reactions and any previous history of uremia, it's contraindicated. And also in the patients who has history of iodine and shellfish allergies. So we need to have this information before administering the ICG. And the side effects that you need to look for is, since we give it under anesthesia, you don't have to look for the nausea, vomiting and all this, but you need to look for the rash, urticaria, and also anaphylactic reactions, which can be seen in the form of hypotension, tachycardia. And you need to be very careful and have the anaphylactic kit ready before administering the ICG dye, which includes, obviously patient under anesthesia will have a wide bore IV cannula. And including that, the adrenaline has to be prepared before giving it to ICG, and also the other techniques that's needed, hydrocortisone, antihistamines, all that's needed in order to deal with the anaphylactic reaction. We need to be prepared with all that. And the other thing is, how does this dye work? Is like it absorbs the light in the near IR spectrum, which is around 790 to 805 nanometers, and it emits the fluorescence, and which is detected by the high resolution stereoscopic camera. And it depends on when we administer the dye is very important. It depends on the organs that we are really focusing on. In 3 to 5 seconds of the administration, you will be able to fastly visualize it in the vascular structures, arteries and veins. And in 3 minutes to 15 minutes, it starts fading into the tissues. And in 15 minutes to 60 minutes, the tissue will start staining. So this timing is very important, and you need to be available with the drug ready to go. And the main applications, as Dr. Jeevarao has mentioned, it's in the laparoscopic cholecystectomies, where you get to visualize the biliary tree, and also in pre and post anastomosis of the hemicolectomy surgeries, where it stays in the intestines for 3 to 5 minutes, and also in the hepatectomies, where you get to identify the hepatic excretion of the dye. And other, last but not the least, is the lymph node dissections, where it has to be diluted with the albumin so that you get to see the microperfusion also. This is very important. And as I said again and again, it's the timing based on the organ that you are looking at. So thank you. Over to Dr. Sanjeev for further information.
So we have Dr. Sanjeev, actually, who is the Associate Director of AIG Hospitals. Actually, he will be doing one case here. Over to Dr. Sanjeev.
Very good morning. So today we'll be demonstrating a case. This is a elderly male who presented to us with history of bleeding per rectum, and on evaluation was found to have a adenocarcinoma of the mid rectum, approximately around 4-5 centimeters from the anorectal junction. So as already Dr. Jeevarao was telling you, we are not concentrating the procedure. We want to just highlight the technology that has come up by Olympus. So basically there are 3 important things that have come up in this Visera Elite 3. One is the autofocus mode, the other is the LO enhancement, and the third is ICG, which is already available in the market and most of the centers are using. So one by one, I'll just try to highlight how it is going to help us in surgery. The first thing is the monitor is projected. Monitor is projected. So if you can see the monitor, we have already put on the autofocus mode here. See, if I go very close to it, it will focus on its own. I think it can be appreciated very well here. And if I go far away, after maybe a second or two, it will autofocus on its own. This is a very important, see, you can very well appreciate this technology here. So this is one thing, because you need not keep on pressing the button or adjusting the focus based on where you are operating. This is one very important thing. The next thing is ICG, which we already know, and most of the centers have already used them. That will be using at the end of this procedure. So here we are planning a low anterior resection. The last is the LO enhancement, which is a very new technology, and we are also in the learning curve. We are also not sure where it is going to help, but our idea is wherever we feel that it could be helpful, we'll try to highlight those areas So turn on to yellow mode. So I am turning the camera on to yellow mode. One important advantage here is you need not give any dye here, only a click of a button, the mode will change. Like ICG, you need not inject anything. That is the most important advantage here. So this is how it looks in yellow enhancement. Initially we might feel that it is a little too bright to operate, but after few cases I feel it is very comfortable. And now with this I'll try to hold the camera, give me left hand. So we'll try to highlight where all this can help. Usually the yellowish structures, most importantly fat here that you can see, enhances very well compared to white light. It will look very yellow. That is how we can differentiate fat from other structures like the intestine. You can see here the wall of the intestine, and this differentiation or contrast variation is significant compared to white light. That is what is very important. So 2-3 areas where it can be helpful is, for example, so here this is a low anterior resection. This is the area of the left ureter here. This is a patient who is not that hefty. There is significant amount of fat here. You can see the fat. This is the ureter. As you can see here, come close. So this is the ureter here. You can see the ureter. If a bit of fat is covered over the ureter, that can't be appreciated, as we all know, and it's difficult to give me the harmonic. So it's difficult to, if a layer of fat covers the ureter, then it is difficult to identify the ureter. But the fat is so beautifully seen here, so we can just pick bits of fat here and clear off the fat around the ureter like this, as you can see here. One second, give me a gauze. Wait. Come close. So this is how you can clearly see even small layers of fat which are very well seen. You can see the type of enhancement, you can yellowish enhancement here on the fat, and you can dissect away all the fat from the structures. This is how you can identify the ureters. Probably we are also not very sure whether it's going to help, but these are the areas that we felt it could be helpful. And the other area is to identify the vessels in the fat. Just a left hand non-tooth locking instrument here. Come back. Come back. Hold here. Hold it like this. Harmonic system. Harmonic.
Good morning, Sanjeev.
Good morning, sir. Good morning.
Pradeep here. So we have eminent faculty here. Dr. Shastri also has joined us here. Pratap Reddy is here. Rajesh Gupta is here. And Mittal is here.
Yes, sir. Welcome, sir. All of you welcome. So you have to give your opinion on this, sir. This is just the first few cases that we are trying to see where this technology will help. So probably in very fat patients, especially in the dissection of the mesentery, in this particular case, we have all. So identification of the vessels is, I feel, one area where, because of the contrast differentiation between the fat and the vessel, I think it could help. So I am trying to demonstrate. So you can see.
Can you switch on to the white light for us?
White light. White light.
Between the.
Yeah, this is white light.
Okay, and show us that fat so that we can.
Differentiate. Yes, yes. In the afternoon, we have good videos which we have operated in our last week lined up, where we have tried to compare both together in the same screen.
Okay.
So few procedures, 4 or 5 procedures. We have yellow enhancement. We have side by side. We have we are running 5 procedures which are done in yellow as well as white light. That can be appreciated well. So in this, you can see the high blood vessels highlighting better than white light. See the small vessels also get highlighted well here. you can see a vessel here.
Yes,
Can you
Sanjay.
appreciate this, sir?
Yeah, Sanjay, keep switching between white light and yellow enhancement. so
White,
that
white,
will
white,
give-
white, white.
Yeah,
This is
all
white.
this. Yeah, this is white light. Yeah.
This is white. Change it to yellow. This is yellow. The contrast is definitely better with yellow light in this particular case. This vessel can clearly be seen on yellow than white, though it can be appreciated, but definitely there is a difference between yellow and white here. This is one area we feel it could help, and the other area is in case of lymph nodal dissection, probably all the fat can be completely cleared with the lymph nodes compared to white light. That is one area, and in this particular case we'll try to see whether it will help in leave this system, leave it, especially in splenic flexure mobilization. Usually the fat on the kidney is covered by Gerota's fascia. If you breach the fascia, then probably you'll easily know that you're in the wrong plane if you are in this mode. So this particular thing I have come back. Just hold this, hold it like this, harmonic there. Come in. See, this is the Gerota's fascia, and it is a clear bloodless field here. As you go in this plane, it is a nice plane. You can just sweep the mesocolon away from the Gerotas here. If you breach the Gerotas, probably there is a significant. I'll just try to. If there is a one second.
Keep switching between white light and yellow light.
White light. Yeah, this is white light. Yellow now. Yellow. Come in.
You're going to breach the fascia?
Sir?
Are you going to breach the fascia?
Yeah, I'll just breach the fascia.
For demonstration purpose.
Yes, yes.
Okay.
Because the autofocus all. Hey, smoke out. Just wait. Yeah. Come here. Yeah. You can see a nice come in. If you breach this fascia, then probably the fat is very much yellow there compared to here. So this is one area where identifying different structures of different color, texture would be probably better with yellow light compared to white light, probably.
Yeah, Dr. Pradeep, actually it is just basically, I think there are no standard of practices that we have in this actually, but I think as we start evolving and start doing these procedures, each one may have pick up some indications for this.
Yeah.
Come back.
Yes, sir. I think we'll let us have comments from Rohit.
Yeah, please, Rohin and Shastri, Dr. Shastri.
Hold this.
Hi, Rohin. Yeah, I think this is good new technology to try out in various operations. Of the had
Lift
things
it.
that come to mind is what's already been mentioned. One is lymph nodal clearance. If you're doing a sort of an iliac lymph nodal clearance, very times recurrence is there because we've left behind fat which has lymph nodal tissue. So we can use this to make sure that all the fat is removed. So that is a potential area for application for this new technology. And again, I think recurrent surgery where everything is fixed and you've got to dissect between fat and some other structure, this will probably come useful. So these are potential areas where we can find a possible use.
I think the another indication would be, it will help us probably know about the mesorectal plane. When we're breaching it, that probably will become more glaring.
I think the best part of this is with just a click, you can change the colors and have an alternate view of things. I think that would be wonderful when you have something in doubt. As a continuous procedure, maybe this kind of thing, you are not used to this kind of colors, so everything looks jaundice here. So I think the best advantage is ease of changing the colors.
Yeah, what Dr. Shastri said is absolutely right. I think the ease of changing just on on a button press actually makes it very useful for us to change whenever we want to change the field of vision actually. And here actually we find it very useful, especially when you are doing this mesorectal dissection. Looks very impressive actually on this yellow light. Sanjay, keep switching between white and yellow so that you can appreciate the thing. Yeah, that is white light now.
Another one thing that comes to mind is dissection in a difficult mesentery, like especially Crohn's or something where wherever you touch it bleeds. This might be more sort of help in trying to delineate the vessels.
Absolutely, Rohin. Actually, I think you are absolutely right. Actually, that is another important indication. See that plane actually we are able to beautifully visualize now. That I think is very important. Actually. Ultimately, we don't have data to show whether this is definitely going to improve the overall outcomes, but actually, but technically, surgical speed could be enhanced actually.
Sister, take your instrument, come in.
But we can definitely, as in today, we cannot say that it will improve the overall outcomes of these procedures. But the dissection definitely, I think, is become more easier for the laparoscopic surgeon.
Okay, no, I think it. Chal, team, go in. Come in. It's getting autofocused on its own. Sister, hold it like this. Left hand on tooth.
Yeah, the other advantage of this system is that it is getting focused automatically. That we usually depend on the assistant to do that actually. This system is getting focused auto. And the number of exchanges are less actually. Number of telescopic exchanges. This they have documented that actually the number of telescopic exchanges that you do in the procedures is less when you're doing this. Basically because you're avoiding cleaning the scope and then it gets autofocused. Rohin, do you think this will make this is slightly more advantageous? See now this especially this area now.
Yeah, I think this is one of the lateral bit is one of the most tricky bits to get right.
Yeah,
and
right.
A lot of new people struggle with this. I think this will definitely help because this plane is, I think, sometimes a bit difficult. So, especially when you're starting out, if you have this technology, it will definitely be useful.
Yeah, and so, I mean, on white light, it slightly becomes messy. We know we have all good surgeons actually use different energy sources, but sometimes it becomes bloody. Actually, these fields.
Yeah, as Dr. Rohina said, because people are scared to move laterally.
Yes.
And they tend to leave a little bit of tissue there to avoid any injuries, particularly the beginners and all. Probably when you can see better, you can be more confident in taking out all the tissues and not leaving any residual tissue there. That's what I think probably should highlight.
Yes, Pradeep.
Take it down, take it, hold this too.
And the biggest advantage is actually when you're combining this with ICG again. Actually, we'll inject ICG now once the dissection is over. We'll inject ICG. The previous systems we had to switch between the telescope sometimes because the visions were not very. There are 2-3 systems available now. Each has got its own this thing actually. But I think as the industry gets involved in it actually very actively, I think we'll get better images. But compared to the previous generation systems, actually, this is lot superior.
Change to white light.
Dr. Sanjay.
Yes, sir.
No, because you can clearly see fat here.
Yes.
Do you think that you can enhance the increase of the speed, enhance the speed of surgery by using cutting when you are seeing fat? And when you see blood vessels, then you use the minimum mode.
Yes, definitely, sir, definitely. Because if you are sure that there is no blood vessel, here even this what I am using is called a thunderbeat, where you have a harmonic and the bipolar together. So if I see a blood vessel only, then I use the bipolar, or else I just go with the harmonic. Definitely it will enhance the speed. If you are able to see the vessels properly, then I may just coagulate where the vessel is there and probably go fast where there is just fat. 100% it will enhance the speed. Yellow light.
Biggest advantage of this technology is, I think, an average skilled surgeon will be able to perform high quality surgery.
Come here.
The quality of surgical specimen you retrieve will be much better. So that is one of the major advantage of these technology.
Yes, sir. Probably, yes, you are right, sir. Probably that advantage may be there for a beginner. Sure. Come close.
I think the learning curve will come down. Technology we use, the learning curve becomes shorter.
I think for this technology, it's fluorescent guided surgery to become more useful. Then the exposure
close.
has to be in the initial years of learning medicine, not at, once we have already started doing surgery independently, but during probably internship or house job, that's the time when they should start this exposure.
What you said is right, Rajesh. Actually,
Come
looks
close.
like all the new scope, the new laparoscopic system that they're going to supply will have an integrated system like this. So I think
White light.
people will be exposed to this sort of surgery. The next generation will be exposed to this sort of surgeries because they are planning to supply only this type of systems now and withhold the other previous generation laparoscopic systems.
Yellow.
So GV Haribhakti has come just now.
Oh, hi. Welcome, Sanjeev.
Hi, JV.
Hi. Thank you so much for joining us, Sanjeev.
Thank you. First time I'm coming to AIG is such a wonderful setup.
Sanjeev Patil is operating now LAR using white light and now he is using a yellow light. And the new technology.
Come back.
But it's just a new technology. Storing where all it can be.
Come in. Yeah.
So this entire platform, basically, we invited such stellar faculty
Hold
just to
this.
give inputs regarding this newer imaging modalities, how it is going to help, and suggestions to improve, whether it is useful or not. If useful, which areas it will be useful, and how to
out your
take this
instrument.
forward.
Wait, please. Just in the part comment. No part right. Okay, వాళ్ళకి ఇచ్చేసి. Come in.
So Dr. GV, can you tell us something about this yellow light mode and where it can be useful?
Hold this in the position. Come in.
Sanjeev, can you highlight the
Yeah, good morning.
Haribhakti?
Yeah, good morning, sir. Dr. Haribhakti, sir. Good morning. Can you hear me, sir?
Yes, Sanjeev, we can hear you.
Yeah. So this is a new mode that has come, this Olympus Visera Elite 3, the yellow enhancing mode.
Yes.
You need not inject any dye, just with a click of a button, this mode will start. So
Okay.
this is called yellow enhancement. That is, those structures, especially fat, which is yellow, will highlight very significantly compared to white light.
Okay.
That is the basic principle.
Okay.
So what physics, physiology behind it all will be talking in the afternoon. But here what we feel during surgery is, in fat, when we are operating, identifying blood vessels within the fat would be better compared to white light. One indication is that, which we already saw and we were trying to demonstrate it. Here you can see, sir. Come. 1 second. Now here. 1 second.
I think you'll have to keep changing between white and
White
yellow.
touch. So this is white light. Change it to yellow. Yellow. So these blood vessels are highlighted more with yellow compared to white is what
The greenish
appreciable.
hue, yeah, the greenish and the yellowish hue.
yellowish. Yeah, the contrast is more compared to white and this pinkish.
Right.
So this is one area we feel it could help, and the other area, 1 second, just leave all the tractions. Yeah, leave. Out. Hold this. Show me this area. The other area that we were. So here, sir, you can see here a bit of fat. If it covers the ureter identification would be difficult. But this fat is very well seen here. With
Change to white light now.
change to white light.
That
See,
is the
the contrast
white
between the fat and this ureter is not much here. Change to yellow. Come close. Change to yellow. See, here we can see the contrast between the yellow and the ureter. So whenever it is easy to dissect the fat away from the structures with this mode compared to white light.
Okay.
So this is how identification of the ureter probably it might help. And in this particular case, we were already showing that if while taking the splenic flexure down, come back. No, I want a traction from here. Maybe hold it here. Come in, camera, come in.
Dr. Patel, another.
Yeah.
Do you think the distance of the camera tip from the tissue is also making a difference?
No, I didn't get you, sir. Distance?
Of the camera tip from the tissue, is that distance when the camera is away, the resolution is different compared to when we are taking the camera closer?
Yeah, the contrast I think is better if you go close. Come close. Come close. Give me a suction or a gauze. That's all blood.
Another thing we have noticed is fat in certain places is yellow and the other places it is green. How do you interpret this difference?
No, so what we have observed is wherever we use the harmonic or any energy source and cut the fat, then it appears more greener compared to. Come, I'll just come here. Come close. One second. Give me the harmonic. Or monopolar. Give me a monopolar. Foot switch.
I think what Dr. Shastri's observation, I think, is a very good observation. In areas it is looking yellow, in areas it is looking green.
Yellow.
From the way it looks, Dr. Shastri, whenever it is slightly stretched, the vascular, this thing is compromised, it looks like it is turning slightly greenish. But the
See, sir, here now it is turning green probably compared to the other fat.
Yeah, right.
It is a little green. It has something to do with the chemical reaction like burning of that fat or whatever blood within the structures causes a little greenish hue compared to the yellow. So that's what we have observed. So wherever we cut, then that area is a little greenish compared to the regular fat. You see?
Now, if you have injected, say, for example, ICG in the ureter or you have something, then does it enhance on this yellow light, ICG?
No, sir.
No.
It has nothing to do with ICG at all.
Okay.
This is purely on just yellow enhancement.
Okay.
Come back.
The way it looks actually, whenever the blood supply is slightly, I mean, once you devascularize the thing, I think the structures look like slightly looking greenish. I don't know whether that is
Even the areolar tissue looks greenish.
yeah, the
The
stretch
TME
on the
plane,
thing,
the
whenever
TME plane.
The
Yeah.
blood supply, I mean, whenever the
Come
blood
to
supply is
look,
slightly
yeah.
less, wherever in areas,
Come in.
see now this area looks green now.
No. So you can see here, so it has a auto focus mode. As we've entered the depth, it is focused on its own. That is one. It's not clean. Camera is not clean.
You see the moment it stretched, actually
Back
it looks
a little.
greener.
I'm
Actually.
not able to see where to. Clean. Don't touch anything. Gently come in. Going. Come back.
Though Olympus says it's yellow enhancement, actually there seem to be two colors that are changing the entire dissection, the way you dissect actually, yellow and green. We really don't know why it is changing.
Come back. It's not clean. All this interactions.
Sanjeev, at any stage you think now we should inject ICG and see actually whether this changes the thing actually?
Yes, sir. Once I transact the distal end, then we'll inject ICG and
See the thing actually.
see where to transact the bowel. Leave it. Sister, listen. Leave it. Come on.
Can you show in any area where both yellow and green are present, and then change over to the normal colors? If there's, you can make a
Yeah, right.
difference, then probably.
Yeah, this area, okay, this is the
Yeah.
bowel looks.
Come in.
Change to white light.
White.
Yeah, this is white light.
Come in. Yellow.
Jai, Dr. Pratap Reddy here.
Good morning, sir.
I have a question unrelated to yellow light or ICG.
Hey, tell me.
The growth is not seen or felt.
Yes, sir.
And laparoscopy, do you use only finger as the guide to transect the lower down, or you use intracolonoscopy?
No, we use PR, rectal examination, I think would be sufficient, sir. Before transacting, we do a rectal examination and then fire the stapler distally. We do colonoscopy once in a while, but not always. Come in. Hold it like this. Come in, get in. Lift the bladder. Come in. Yeah, hold it like this. Push it down. Yeah. Come in. I mean, don't shake the camera.
Is this a system you already bought it, or you're just trying and planning to buy?
We have one system already here with us, Pratap, actually. You already have the system actually. Because the previous ICG, this is an upgraded version of the previous ICD machine that we have.
I know it may be too much of asking such a question in this conference venue, but what's the cost difference between this and the others?
No, they haven't yet released the cost yet actually. I think you can talk to the Olympus.
Because for a lot of people that
Yeah.
is becoming an issue.
Yeah, I know, correct, Pratap. Actually, what you said is absolutely
Yeah,
right.
when we discuss, the usefulness versus the cost.
Yeah,
that
right,
is-
right.
That is becoming a big discussion point.
But I think with more and more competitive brands coming in the thing, actually the initial pricing for any of these technologies could be high, but I think subsequently it will come down. Like what happened to the 4Ks and HDs right now?
I know.
1 second. Just I want one more instrument to.
What is the light source? Is it xenon or LED?
LED. This is an LED light source.
Come back. Ready, just come. Here the differentiation of fat. Come close.
Change to white light now. Change to white light, and then see that. Yeah, right.
See, here the contrast between the bowel and this fat is
Now change to
minimal.
yellow.
Change to yellow.
Yeah.
Now the contrast between this fat and this bowel is so good. Center, camera center. Don't shake here. This contrast is good, yeah. Suction. Inch. Come in. Here, anteriorly. Harmonic, harmonic. Come in. Wash, sister. Wash. Suction. Wash it fast. Wash. Come in. Marylands. Come in. Harmonic. Come in. Come in, come in. Action humor.
But Sandeep, could you find any blood vessel in the tissues which you are cutting here?
Then I
I'm
get
sure there were some.
Yeah, there was a blood vessel here, but I think the disadvantage is if there is bleeding, then the whole thing becomes red. That yellow enhancement goes away. There was bleeding from this small vessel here, which we used bipolar and we have stopped it. From here there was bleeding, but once there is bleeding, then the yellow thing will go away. It will just look everything looks red. Come back.
That is when you need it most.
Yeah, that is right, sir. But to avoid such a thing to avoid, I think yellow will help. But if it happens, probably it may not help. But most of the times you can avoid it. You can see the vessel and then use before it bleeds. Hold it like this. Hold it like this. You have to use this here. You have to. No, same.
Is Dr. GB around?
Hold it. Yeah, come in.
Dr. GB, are you there?
Come in.
Yeah, Sanjeev.
GB, I just wanted to understand
come
what is the origin of this yellow light? Is it come from endoscopy? Do they have this kind of a mode there?
No, they have a different kind of mode on the endoscopy side, which they started using for third space now, Sanjeev.
Okay.
Now, there they use, I think they call it as HD light or something of that sort,
Okay.
which has got again a filtered. Basically they're using filters here to see which light is better.
Okay.
So even there, actually, they have another mode on the endoscopy side, which is improving the visibility, especially in the third space.
Okay.
So this is similar concept, but here they using the filters to enhance the yellow light here.
Right. Okay.
But it is likely that actually, the R&D work that keeps going on, tomorrow they might use another filter to see whether it is going to be helpful.
Yeah. Red
But-
enhancement or something.
Yeah, see, basically, but now what the industry tells us is basically fat being yellow, they're trying to see if it can be enhanced. And enhancing color, they want a contrasting color between yellow,
ICG
red,
we
and
can give
green.
and see.
Right.
So that is the concept of using these
Come back.
filters when
Come
they're
here,
doing
come
this.
here, Come here.
using
Come
this
back.
platform.
ICG.
Now,
You
I
can.
think what I understood was compared to the previous system, previous 4K ICG, this is far
Yeah.
superior.
ICG mode. You can
Yeah.
PIP. You can give na ICG mode.
Now we'll see the thing when we switch to the ICG mode, we'll see what the clarity that we get on this.
Harmonic EMA.
So does this have a white light ICG also?
Yeah, it has a white light ICG.
Yeah,
So
yeah,
now we are injecting ICG here
Okay.
to see the line of
Switch between white
transaction.
and yellow actually. When you're injecting ICG, we can switch between white and yellow.
The other feature that is here is, sir, we can have both ICG and white light pictures simultaneously on the screen. PIP.
Yeah, we can
picture
ask them
in
to
picture.
put that, Sanjeev, actually. Put them simultaneously together if possible.
Come back.
Can
Each.
anybody from Olympus put
ICG
both the
mode.
pictures, please, actually, if possible?
ICG mode.
And
Start it, no? Given, no? ICG mode. ICG mode on, no?
Can you zoom out a bit? You should see the entire sigmoid colon. That
Yeah, you can see the ICG appearing here. Yeah. You can give a PIP. PIP. Sister. Take this out. It is same in the bed. I take this. Give me another. Hold this. Inko instrument here.
now this is under white light.
PIP.
Yeah, this is under white light.
You have to keep it ready, no? Getting it from where? You can see the difference.
Area of differentiation. Yeah, that's
Yeah, you can see the difference here. It's a nice differentiation of.
Very nicely seen.
This is
Yeah, very nicely seen.
ICG is definitely useful actually to check for this sort of a. This is very clearly demonstrated.
Yes.
Very good actually.
Can
we change to yellow light now and see?
Yellow light?
Can you go a little bit closer and
Close.
little bit
Close,
away
close,
and see
close,
whether
close.
is there any change? Yeah. A
This
little bit away. Camera
Away.
away.
So now you have both modes on the same screen.
Right.
You have white as well as yellow. So you can see the clear differentiation between the advantage of ICG here. Here it's not that there is no significant contrast differentiation, but in this ICG definitely you can make out the line of transaction.
Yes, yes. We have just one view here. We don't have the other view.
I think we're getting only one image on the other side, Sanjeev. So we'll just switch to yellow. This is yellow
No,
light.
sir, you are not getting PIP.
No,
we
we
are not getting.
No, we are
No,
not getting.
PIP is not transmitted.
No.
That's okay.
You
That's
can
okay,
show the
Sanjay.
white.
White light, white light.
Change to white light now.
Yeah, this is white.
Okay.
Yellow. Now, sorry, ICG.
Yeah, this is white light with ICG.
Okay.
Now we switch from, see here, the devascularized bowel also is looking slightly, okay, right, let us see
Yeah.
the thing, okay,
Can,
fine.
can we go to yellow light with
Can we-
ICG?
Yeah,
Yellow light. Actually, sir, once you give ICG, once the ICG comes in the artery, so that is the time when you have to
Yeah,
demarcate the bowel. It is too late now, so some venous congestion is seen even in the distal specimen here. But initially it was very clear.
yeah, right.
There was a transaction line here, but now there is some amount of greenish hue here because probably of venous
Can you switch over to yellow light?
yellow light, yellow.
The best contrast image will be between 1 to 2 minutes.
Can
Ah,
you-
yes, sir, correct.
Can you have the ICG with the yellow light?
No, you can't, sir. You
Okay,
can't do that.
Okay.
You can't do that. So now what I'll do is I'll transact the bowel and then do a circular double staple anastomosis, and following that again we'll give ICG and see the anastomotic vascularity. Stapler system. Let's switch. Staple this one. Take your hand. Come back.
It's during the early phase only, it's better you put a mark
Yes, correct, sir.
or staple it at that time. Otherwise, in delayed films, it's very difficult to know the transition.
Staple it. ఏం కోవిడ్
Timing is very important.
Huh?
Yeah, first 1 to 2 minutes. What we are doing is we put a staple across at the potential site of
Don't you?
demarcation and confirm with ICG. At that time only, we just apply the staple.
Where is your hand? Just take the bubble and
Depending on the vascular transition.
come in, camera, come in. Back here. Come in, camera in. Hold that. Okay.
Sanjay, did you confirm whether it
No,
is
I'll
deep at
confirm, sir.
margin?
No, I'll confirm, sir. It is significantly higher up. I'll just reconfirm it, sir. Just give me a glove. Hold it like this. Give me a glove, please. Sir, we have at least 3 centimeter margin, sir. This is the transaction line here. So I can feel the tumor posteriorly. It is quite higher up with from the area where I have denuded the bowel.
Ah,
At least
Yeah.
3.
I just asked the question. Sometimes here you may be feeling the growth, but post neoadjuvant in some cases there's hardly any growth.
Correct.
There is residual only some small ulcer or fibroid.
No, there definitely we do use the colonoscopy, on table colonoscopy.
Yeah,
Sir.
that's why I asked.
Yeah, definitely we use that. always we have a colonoscope on in the theater here. So whenever required in such doubtful cases, we definitely do a colonoscope and then give me my hand. Leave that. Leave it. Come in now, come in. Wait. We'll use one more. Okay. One more glove. This is a I waited for 15 seconds, so now I'll fire the stapler. Come close. One more reload system. Left hand on tooth. Hold on. Not Patpaduman, don't hold that. I'll tell you what to do. Sister, harmonic to me. Harmonic. Come in. Come back. Show me from here. Come in. Staples. Come in. Wait.
Recording stopped.
Okay, wait for 15 seconds. Actioning. Come close. Come in. Scissors, give me a scissors. Pin there, huh? Scissors ఇచ్చేసి. Come in. Harmonic to me.
Okay, Sanjeev, now that is, we'll just switch over to the other theater.
Yeah, sure, sir.
Dr. Pradeep, we just doing that. And Dr. Shreyesh is there on the other theater.
Come in.
Again, we are not saying that this has to be used in this. Actually, Shreyesh is you doing a distal pancreatectomy. We're just trying to see if this yellow enhancement has got any advantage
Suction.
during this mobilization of this thing.
Yeah, sure, sure. Sir.
So can we change over to the
Wash.
Dr. Shreyesh, please? Shreyesh, you are live, Shreyesh.
Am I audible, sir?
Yeah.
Yeah. Good afternoon to all the faculty that is present in the auditorium. So I am doing a distal pancreatectomy for a 28-year-old female with solid pseudopapillary tumor in the tail of the pancreas. It is around 10 by 8 centimeter tumor. So I already mobilized the colon down. I am using the yellow enhancement mode that you are already seeing in the other theater. So the colon is down. You can see the exposed gerota. So what I have observed in last few days is once the fat is exposed and the fascia covering the fat is divided, the fat sometimes becomes more greener. So it might be that the light coming from the fat might be getting obstructed. The color coming from the fat might be getting obstructed because of the peritoneum. So you can see the difference. This gerota is covering the perinephric fat, and once the gerota is breached, once the gerota is breached, the fat becomes more greener side. So it is basically a pure exposed naked fat that looks green. The fat which gets covered by a fascia looks yellow. That is the observation that we are seeing in the last few days. So as Dr. Sanjeev said, so this what is it? Hearing? I am talking.
I think whatever data they have from the industry is basically to show the enhancement. I think now it is for the surgeons to see how useful it is, whether this technology is useful or not. See, sometime back what happened was actually we knew that actually because we have this narrowband imaging on endoscopy side, they tried to introduce this narrowband imaging onto the laparoscopy side. But basically when we tried using narrowband imaging or the blue light, there was no difference actually. It hardly had any impact on the nature of dissections. So subsequently they have withdrawn that actually. So initially for some time we had this narrowband imaging, even it was available for the laparoscopic surgeons. So this actually, after that actually now they're talking about this yellow enhancement now. So I think we just have to use this and see how it is going to be useful in dissections. But compared to the narrowband absolutely had no use in laparoscopic surgery because basically it was more onto the mucosal side. It had its advantages. Shreyesh, do you think pancreas is enhancing more when you're in yellow light? Actually, have you seen that?
Pancreas looks yellow, sir.
Better,
I will just
actually.
show. Come back.
Compared to white light. Okay, then let us see. Okay. Now change to white light, Shreyesh, and see.
White light change. So this is the pancreatic tissue stretched
Yeah,
over the
right.
tumor. So we'll change it to white light.
Yeah.
Change it.
Yeah. So
it is all
I think again,
different shades of yellow
Sanjeev,
with pinkish
Sanjeev, do you think there is any difference now, especially the tumor in the pancreas? Pradeep, change to yellow light now. Yeah, definitely. I think we are able to see that.
the
stretched
pancreatic
out
tissue, you can
pancreatic
see, yeah,
tissue on the
pancreatic
tumor is
tissue is
visible
stretched out over the tumor.
better
Yeah.
in yellow light compared to
And
white
we'll just
light.
show this. I will take down the mesocolon. So the boundary between the mesocolon and pancreas is very well delineated.
Pradeep, what do you think, Pradeep? Actually, pancreas seems to be better visualized here.
90 degree.
Is Dr. Sanjeev or Dr. Shastri there to comment on it?
Sir, I think the fat on the pancreas appears much brighter with the contrast.
Okay. Even the pancreas, which looks slightly pinkish on conventional white light,
Yeah.
it
So
looking.
you can
more-
see the pancreatic parenchyma
Yeah, right.
and the fat clearly.
Maybe.
Because normal with white light, it's very difficult to find out the whole
Yeah,
pancreas,
right.
particularly fat-laden pancreas,
Yeah, right.
which is very difficult.
Can we
in
switch
the
to white light now?
White
Suresh,
light?
actually keep switching between white
Yeah,
and
yeah.
yellow light. Just to see the difference. Yeah, right now that is the white
So
light.
now you can't discriminate between the thin fat and the pancreas.
Yeah, pancreas. Right. Absolutely.
Rightly
right.
said, sir. It is all different shades of pinkish yellow.
Uh,
So when it is changed, the color differentiation is more.
Yeah, right.
Change it?
Change to yellow light now. Yeah, definitely. Actually, there is difference
the
between.
fat,
there is
particularly,
a
it
difference.
might be useful when the fat-laden pancreas to
Yeah, absolutely
remove
right,
it and then expose the pancreatic parenchyma. Is even with open surgery, it's a problem.
Yeah, right. Pradeep. Correct. Absolutely. So looks like actually bowel and pancreas also it's useful actually. We're not so much worried about the dissection of the momentum or whatever it is, but I think when you're dissecting the pancreas, I think it looks. I think we should ask Dr. Shastri and Dr. Sanjeev Haribhakti the comments actually, because all these comments are being recorded, please. We're taking all the feedbacks are being taken to.
So they just have a cup of coffee.
Okay,
They'll be
right,
back, now.
Right. But I think it certainly has some advantage, Pradeep, actually, compared to the white light that we're using actually. Very good dissection, Shresh, actually. Very good.
Even the differentiation between blue color and yellow color is in very stark contrast. You can see the veins even beyond the fascia. So,
Just change down at that.
I will just show that left renal vein that is
Yeah.
thin.
Right.
Suction. Dip the tumor. Okay.
I think the biggest problem will come to us, Pradeep, when people start operating under this yellow light and they want all the systems to be changed to yellow light. Then it becomes difficult actually.
On to
Sanjeev is here. Sanjeev.
Yeah, Sanjeev. So,
Yes.
Sanjeev, we're just trying to see this actually. The pancreas seems to be better visualized under yellow light actually.
Okay.
Especially the
Shift
fat
to
laden
yellow
pancreas.
light?
No, it's better visualized. Actually, we just saw some of the images.
Okay.
normal light.
Yeah, here again.
So I am trying to demonstrate the left renal vein beyond the gyrotous fascia. Shift it again. So there is a little bit extra difference between the colors between
Yeah,
the
so, okay,
perinephric
the
fat as well as
visualization is
this.
slightly better. Yeah, right.
And second thing that I wanted to demonstrate here is this fat that is covered by a fascia looks yellow, but when the fascia is breached, here
Yeah,
the
right,
gyrotis is breached, it looks green. So any naked fat will look green,
Okay.
and
right,
fat
right.
covered by fascia will look yellow. That is the observation in last few cases.
Yes, Shreya, Dr. Sanjeev Haribhakti is here. He just wanted to see the pancreatic images.
Yes, sir,
actually,
yes,
what you showed
I will
initially.
show.
Now, this is yellow light, Sanjeev.
Yes.
Now,
So now
see,
change
I mean,
to white
we're able
light.
to see the stretched pancreas over the tumor.
We can see, but not very clearly from the peripancreatic fat. Because,
Yeah, now here. Now,
Yeah.
this is the white light.
Okay.
This is white light. And
Mhm.
then switch over to yellow light now. Yeah, right. So, if you're So we seem to have some advantage here actually, especially a fat in pancreas.
Maybe the fat is enhancing much more than the
The
pancreas.
yellow,
Yes, sir.
Maybe
basically
that's
again
creating the
yellow
contrast.
enhancement again.
Yeah.
I think maybe same thing. I think maybe a chronic pancreatitis pancreas may not enhance so much.
Training there, no?
Shresh, keep changing between white and
Yes,
yellow
yes.
just to see the thing. That's what
Change it.
yeah, but that's what we are all looking for.
చేంజ్ చేసి ఉండండి. Keep it changing. 5 minutes this, 5 minutes that. Stay here only.
Yeah, this is white light again.
So the contrast does seem to help when the vessel is to be
Yeah,
dissected.
Yes, sir.
absolutely right. Right. Very absolutely right, Sanjay.
Change it again.
Yeah, right.
Maryland.
Basically, I think as we keep doing procedures, we'll know where it is useful, where it is not useful, and maybe subsequently boil down to some select procedures where this can be used.
My only concern, GB, would be that if you get too used to this kind of contrast, then working on a white light will become more difficult.
That's what I was telling Pradeep just now. Actually, if surgeons start asking for all this stuff, then it becomes very difficult for us, actually. Change to white light, please.
White light?
Once. Change to white light. Yeah, right. Okay, yeah. Contrast is definitely better. Hello.
GB,
Yeah, Sanjay.
we have other people joining us. Dr. Rajan Saxena, Dr.
Oh, hi,
Sadit
hi,
Sikora,
hi.
and Dr.
Yeah.
Sujoy Paul have joined us.
But now you're experts in yellow light. Now I think you should take the discussion forward. Hi. Good morning, Rajan. Welcome. Again, actually, I mean, it's amazing that so many senior faculty have agreed to come to give opinion about this neuroimaging technology. We're all thankful to you all for sparing this one day here.
స్టేపుల్ కాదు అన్నమాట ఇది థండర్ ఇష్యూ
We tried to use ICG for pancreas, but actually pancreas for ICG is not that very good actually, but we never tried using ICG in this newer platform. Maybe we should try using, because the system seems to be better compared to the previous generation one.
याच्यासाठी चांगलं आहे back seal is there, na? SME, that is the clinic vein. Come on to.
Yeah, there is a suggestion that actually it could be good for adrenal, Sanjay.
Yeah, for sure. I think the smaller veins of the adrenal
Yeah.
veins could be better identified.
I can show you the sir adrenal veins. Here it is seen.
Differentiate between the adrenal gland and.
So do they have the same system on the 3D platform or is it only on the 4K? You are operating on the 4K, right?
4K, sir.
Okay.
Do they have that same thing on the 3D?
Now the next one they have, they're saying they're going to incorporate 3D into this now.
Okay. Just by software.
Yeah.
Sanjeev sir, hello.
Yeah. Yeah, you're audible, sir. Sure.
Yeah. Can you appreciate the veins, sir?
Yes, sure.
Beautifully seen,
You can
sir.
see it very well.
Yes, sir. So you can differentiate between the different shades of yellow also here.
Because it's a yellow light. New technology that Olympus is just launching today. Yeah, can you show this with the same white light so that you can see, people can see the difference?
Yeah, right.
Yes, sir. Yes.
Yeah,
Change
please.
to white light now. That is
Come in.
white light now.
This is a yellow light, isn't it?
Yellow light. This is yellow light.
Yeah.
I will
now
change
can
to
you
white.
show-
White light.
Yeah, the difference is subtle on the white light, and
Yes.
it is
More.
exaggerated in the
Yes, sir.
yellow light.
That's why it's called yellow enhancement actually. They call it yellow enhancement actually.
Right.
Change to yellow light now.
So that is the adrenal gland that is seen.
Yeah, right. Now you see the thing.
Let's see how it looks like. The yellow light. Come in.
Hmm.
Yeah. Change to white light now. Yeah, right. Certainly there's some difference actually. Yellow light phase. Yeah, now right. That's good, Paresh, I think. Yeah, you can continue your dissection.
Yeah, I will continue with my surgery. Yeah.
But here I think the stretched out pancreas is looking very impressive on the tumor. no?
Yes, sir. On to. Rotate.
The other thing for people who
Most
joined
likely that one.
this thing is actually the autofocus on this is limiting the number of exchanges that we have during the procedure.
This is splenic, sir. This is splenic. That most probably is coronary. That one.
Yeah. Shreyas, we'll just go to Dr. Sanjeev and come back to you.
Yes, sir.
By the time you come to the transaction. We'll just switch to Dr. Sanjeev Patil here. Sanjeev, you're back, Sanjeev.
Umbilical tape.
Hi, Sanjeev.
Hello, sir. Good morning.
We are back
So-
with you.
Cook. There is some amount of fat here. I'll take it off and we are ready to come in camera. Just a bit.
Again, Sanjeev, some of the faculty members have joined right just now.
Marylands.
Yeah, if you can just show the same concept here again and then.
Open. Just keep it like this. Open. Gentle. Come in camera. One minute. Close it. Thoda idhar. Open.
So did you do the ICG on the
No,
lower
sir.
stump? Lower stump?
Lower stump after the anastomosis, we'll do it from below, sir, transanally. We'll see using the same scope.
Not before the anastomosis?
Before also we can do, sir.
Why don't you?
Yeah, we can check the.
Yeah, we can now check
Inject-
before also,
inject
not
one
an issue.
time.
ICG, please. Come in. Come in. Show me the anvil. Come in, camera in. Yeah. Just to give me another
Nahi,
instrument.
Can we have the ICG, please?
ICG, please. Given, na? ICG mode. Come back.
Change
Come
to
back.
white light, Sanjeev. No.
White
Change to
light and
light.
ICG mode. Yeah, changings. Come back, camera. Show me the lie of the intestine. ICG mode, huh? Okay. Show me the lie. Intestinal lie. Come, show me up. ठीक है, go down. It's okay. Go down. Back. Yeah, you can see the ICG appearing here. Show me this part, no problem. How much ICG given? Hey, the dose you have given, I don't think is sufficient. Huh? Yeah, you can give, no? 108.
Is this ICG mode or the yellow mode?
No, this is ICG mode.
ICG mode.
ICG, yeah. Just now the ICG is given. We'll. वेट कुछ नहीं है, बैलेंस नहीं रहता. Given, na? Okay. Yeah, now you can see the right for the
What about the lower stump?
lower stump. Yeah, lower stump I'll show. Come in camera, come in camera, in. Just wait. It might take some time.
Go to the proximal stump.
Proximal. Tighten it, let us see. Tight. Two. Just come in.
Is it that, we are not able to see that enhancement on the stapler head, the anvil head? Is it because of the stretching or you think it's because of the low vascularity?
No,
That's
not
because of
lower.
the stretch, I think, Sanjeev. That is
Probably because of the stretch, sir. So what after the anastomosis we can see transluminally.
Okay.
So that will be appreciated very well. There won't be any stretch there.
Fine.
Come in. No, just hold on. Yeah. Tight. Nicely tighten.
But you'll have to put in the laparoscope transanally, right? To see that?
Yeah, the same scope we can use, sir.
Then you won't be able to use that again.
No, we have two scopes now.
Okay.
We have another standby scope. So if we do this, then we won't use it again transabdominally. We'll tighten it off. Wait for 30 seconds. It is in the green, no? Okay. This is IR, no? Oh, this will keep. This will use. Okay, fire. Lock open and just hold it. Yeah, come in, camera, come in. Open there. Lock. Open, 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 open. Gentle, don't shake. Open. Open, open. Keep opening. Open. Just wait. Open. Hmm. Just hold on. Hold this. Check for the donuts. Now this scope to me. Give me a 12 mm port.
Can we check from the ICG from above also?
Yeah, yes, sir.
Laparoscope first, then transanally. Or maybe if you have two scopes together. One.
No, we have two scopes, sir, but we have only one IR scope.
Right.
So that will go from below, from above. You can't see. What we'll do is we'll check from above first and then go down.
Okay.
ICG. That much is not a full length. One more dose. Okay, you see from above. Donuts are fine, na? Okay, okay. Yes. Port डाल लेंगे 10 mm port है ఇక్కడ ఉంది అది ఇచ్చేసి IR mode is on. ఏం ఇస్తున్నారా మీరు? Come back. Give me another ICG. Is it given? IR mode, ma. I want IR mode. ఇచ్చేసేయండి ఒకటి ఇస్తే పర్లేదు ఫుల్ డోస్. Yeah, that giving. Oh, ఇచ్చేసేయండి. Given, no? Yeah, give. Yeah, given. Come close. Yeah, no. The green out. Huh? No. Come back. Leave your hand. Leave it loose. Okay, come in. Yeah, now you can appreciate, sir.
Yes, yes.
A little back, and closer. Go close, go close. Yeah, if you go close, it's appreciable.
The enhancement is there, but it's quite patchy actually.
Quite, yeah,
It's not very dense and diffuse kind.
come back, go up. ICG whether what they are giving is perfect or not. The green. नहीं sir, wash out हो जाएगा वो. Come in. Yeah, hold on. अरे, we'll see from below, sir. From below. Little higher. Give another scope. Keep it away, keep it from the side. ఈ స్కోప్ ఇక్కడ ఇచ్చేసేయండి. Take this here. Gas connect कर दे सर. Shall we connect gas? No. Empty చేసేయమ్మా. लगा दो सर. Gas. Quite deep inside. What this one? Yeah. Nice. Air लगा देंगे सर. Air insufflate. Yeah. This is the gas connect कर देंगे. Give a dose of ICG. But I don't know whether it is sufficient.
So are you planning to do a leak test, Sanjeev?
Yes sir, we are planning to do leak.
Yeah, you can now see very well. Good enhancement.
Possible also. Is that okay? Is that okay, Sanjay?
The proximal one is very good.
The proximal one. We
Yeah.
just wait for the distal one. I think that will also get enhanced.
Yeah.
Yeah, now it's getting enhanced now.
Yes, now the distal one is also good.
Yeah.
Right.
Yes. So was it the dose or was it what was the problem?
It was the dose. Actually.
Probably the dose.
Dose.
Okay.
So what I did was actually I put this 10 mm trocar here below because I didn't want to insufflate connect the regular gas here. I'm using a T connector injecting some air here
Okay.
because I don't want to overinflate the thing also because otherwise the ball tends to get distended again.
Right.
So we just connected it to a T connector and you're using regular air to just to insufflate the thing.
Wouldn't it be better to use carbon dioxide rather than
Carbon
air?
dioxide, but the flow at which we have
Right,
this thing,
right,
even if you
right.
put it at a low pressure,
Yes.
the proximal ball tends to get filled up too much. Sanjay.
Right. Okay.
Thank you so much. We'll just switch over to the other theatre.
You are
before
not
we
planning
go
to
to the-
do stoma, right, Sanjeev?
Yes sir, stoma.
Stoma, no stoma.
No, stoma sir, in this case stoma, but
yeah,
but-
is good.
No,
The test is good.
no.
we
ICG.
do an unmatured stoma.
So what we have, if it is a little higher up, we have avoided a stoma most of the cases.
Okay.
But this was too low down.
Okay.
So in such cases, still we tend to be safe than sorry.
Okay.
So we still do a stoma for very low anastomosis.
Okay.
We'll switch over to the other theatre, Sanjay.
Fine.
and
Thank you. Thank you.
Thank
very
you,
much,
thank you.
Sanjeev.
Sister, take off the scope and hold. తీసేయాలి మరి ఇది
Come in.
Okay, so good afternoon. So we are almost completing the retropancreatic tunnel. There is some bleeding from drainage vein. Yes, sir. Maryland. Right. थोड़ा right up करना. Right up position.
So Shreyas, you are standing on the right side or in between the legs?
I am standing on the left side, sir.
On the left side of the patient.
Yes, sir.
Okay.
Harmonic. Yes, sir. That is very good. Harmonic.
We can see your camera person is in between the legs, right?
Yes, sir.
So the position is leg apart.
Yes, sir. No, sir. The tunnel, it is there. Yes, sir. Akshanam.
So could you identify the splenic artery?
Artery, yes, sir. We are seeing, but we are not yet isolated.
Okay. Are you planning to get it first or
I will
after
see,
the
sir, if it
division
is
of the pancreas?
most probably after division of pancreas,
Okay.
because the tumor is very bulky and looking towards the medial side. This is the coronary that we ligated. From the specimen side, it started bleeding, so we had
Right.
packed it here temporarily. Back.
Thank you, Shreyesh. Actually, for want of time, I think because the stapling part is left, because our entire concept was to showcase this ICG and LO enhancement. The faculty are also quite tied up for the entire day. We'll break for lunch.
Dr. Rao, just a minute.
Yeah.
Rajesh. So can you show us the ICG difference between the tumor and the pancreatic parenchyma here?
Oh, here actually.
Yeah, we
Okay.
can do, sir.
Yeah, Sanjay, okay. Yeah, Shreyesh, try the white light,
ICG.
change to white light and then see. And ICG injection,
Sir.
can we have?
Yes, sir. We'll prepare and
Lakshmi?
inject in 5 minutes.
That's a very good suggestion actually. Even we wanted to check, because initially when we were using the previous system, we did not find much difference between the ICG when we were using it for pancreas. But this, I think we should.
Also, I think this differentiation may be different for different tumors also.
Yeah, absolutely. That's also a very.
ICG prepare చేస్తున్నారు ఎవరు?
Anybody? Dr. Lakshmi is there actually too.
Yes, sir. Anesthetists are preparing. Come in. ठीक है. Artery. I will divide the pancreas first.
Excellent. Contrast and maybe the extent and
The origin of splenic artery. ये पकड़ो. History also doing something.
Then
Isn't it?
Slightly plus also extend.
actually, normal color, normal.
It is ready, huh? Hospital. Okay, I will keep that. Here.
Is it already given?
No, sir. Action. Add more.
No, it'll take
Press
some
one.
time. It's still in the tube, Sanjeev. We just have to
Press
yeah,
one.
flush it actually now. Yeah. Yeah, I can see the vessels now. Yeah, right. Absolutely. Can you appreciate the thing, Sanjeev, now?
Yeah, we can. I
Yeah, right. Actually. Yeah, I think actually this system, the pancreas is also enhancing very well. Very
With the gain?
beautiful images.
ICD gain decrease. Okay.
Change to white light now. Yeah, this is white light, IR mode. Yeah, and increase the enhancement please. Gain, yeah. No, decrease the
low
gain,
gain.
decrease the gain, decrease the gain. Yeah, this is very good actually.
For a highly vascular structure, low gain is
Yeah, right.
enough. Normal mode. Can you change?
Thank you so much actually. So for want of time, I think we'll, Dr. Pradeep, can we just take all the faculty members for lunch in the 5th floor library lounge? We'll join you there and then we'll start the afternoon session in time so that we can finish the entire session in time. Thank you so much once again, and I sincerely thank actually almost about, looks like about 740 people logged in to see this procedure. Olympus has made tremendous effort to do this. Thank you so much, and I hope that this imaging would improve our quality of laparoscopic resections. But I think we'll have more interactive discussion in the afternoon when we'll discuss about the pros and cons of this new technology that is being introduced into clinical practice. Thank you so much once again. It's signing off from the theaters in AIG Hospitals.
Thank you, Dr. GV, and thank you all the OT team, Sanjeev Patil and Shreyash. Thank you.
Thank you, sir. मेरे लैंड सक्शन है वो मेरे लैंड को
Ah. है फुटस्टेप्स का सोनाली बड़ा से मंगाया है ये वाला बोला स्पेशली मेरे को परेशान करने के लिए वहां से मंगाया था ये क्या है मतलब छोड़ो ये तो करना है ना व्हाट है वो? Very bad. लेकिन मोटा है
Hello, check.
Good afternoon, everybody. At the outset, on behalf of the faculty and staff of AIG Hospitals, a warm welcome to all the stellar faculty we have. Actually, this meeting was supposed to be in a boardroom, but to a live audience, we have already about 300 plus audience who have registered online from across the globe. This was initially mentioned for an online meeting. In addition, some local delegates would come in. But finally, the Olympus people wanted a bigger screen to showcase the yellow enhancement and the ICG. So we shifted from the boardroom to the auditorium. So we have about 350 people who have registered online, and we are going live both on YouTube and Facebook. The entire meeting has been going live on Facebook and YouTube. So the last 2 decades, actually, there have been a lot of things that have changed the entire way in which image-guided laparoscopic surgery is being done. One of the components seems to be image-guided surgery, including ICG-guided surgery. Initially, we did not have much good images of this, but with the industry taking keen interest in this, a lot of modifications have happened, and we have some very good imaging technologies that have come in to make sure that the minimally invasive surgeries are becoming better, and it is likely that people will change over to the newer imaging modalities that we have. The company seems to have tried initially narrowband imaging on the laparoscopy side, but it was very good on the mucosal side, but it did not take off much on the serosal side. So now the Olympus has launched the Viscera Elite system, which has got an enhanced ICG and also enhanced yellow enhancement facility. So we wanted to see, basically it is not that we're trying to showcase this, we wanted to have opinion of key opinion leaders from across the country to see how this is going to be useful in clinical application. So for the same reason, we had some live transmission in the morning to take opinion from different faculties from across the country to see how it is going to be useful in. The other thing that has happened was actually, I never thought all the senior faculties would accept for this invitation on a very short notice. But I sincerely thank all the faculties from across the country who accepted this invitation. And more so, it is not a meeting, basically it was supposed to be a group meeting, but we shifted the entire venue to the auditorium just to make sure that we get good images on the screen. Thanks Olympus for the entire support they have rendered for this meeting. And we also have our official partner, Sun, as an official partner for this meeting, for taking care of the logistics behind this entire meeting. We sincerely thank each and every faculty member for having spared their time. And more important than this, actually, we wanted feedback from all your people so that we can take this forward. Because this has become a separate specialty by itself. Whether you don't know it or not, actually, there's an International Society of Fluorescein Guided Surgery right now, which is very active and is trying to promote these surgical procedures. So without much ado, I think actually we'll start the proceedings. I'll ask Dr. Pradeep to take over. And I'll ask the first set of people, Dr. Pradeep, Dr. Pratap, and Dr. Upendra to come and share the thing, actually, Pradeep. And I request Dr. Pratik Arora to start the thing, actually, talk about the basics of imaging in surgery. And we all hope that everybody will keep to their time. We'll end the meeting in time so that we'll leave complete all the proceedings by about 6 p.m. today evening. Thank you so much once again.
We'll ask Dr. Pratik Arora will be briefly talk about the imaging in surgery. Dr. Pratik, please.
A very good afternoon to the esteemed panel and to all the consultants who have come from the country. I'm very honored to be presenting this presentation, even though it's very basics in front of you. So, a very good afternoon from the team AIG here. So the topic it's just a basic topic. So to start this presentation with, that is imaging in surgery. But when we look at the topic, so when you start researching about it, you go onto the net and you think, what are we discussing about here? What imaging are we talking about? Are we talking about ultrasound, X-ray based, MR, or the newer technologies that we are actually discussing about? And when are we talking about this imaging? Is it pre-op, intra-op, and post-op? All these are acceptable answers for a topic like imaging in surgery. But what we are actually discussing is the new thing which has come up, that the things that we used to see with our eyes, the live tissues, and now with the advent of laparoscopy, there are a lot of technological advances and the instruments that come between our eyes and the tissues. So this is actually what I'll be discussing here today, that imaging and laparoscopy, that how the pathway from the tissues to our eyes actually goes through a lot of newer advances, processors, and finally comes up to the monitor. So this would be my presentation here today, and all these components which are present in between, I'll try to cover them very concisely and in a very brief manner. So to start with, here I would like to include tissue also as a separate component compared to an open surgery, because with the help of technological advances, the tissues properties can be changed. The way we are seeing the tissues, I completely accept that in this process, the major role is of the light which is shown onto the tissues and the image processing systems. So, but inherent properties of the tissues can be used to differentiate between the different kind of tissues. That is, for example, the yellow light enhancement is using that. With the help of blue-green light, NBI is using that. Or if you are putting some dyes from outside, then the indocyanin green that we are all aware with. So we are able to change the characteristics of the tissues so that we are able to see the unseen in a way. The second point here important is the light source that we are using. So there are two important concepts here. Number one, the light source machine that we have should be able to give the light that we use for a normal laparoscopy, and secondly, it should be able to generate near infrared light or a blue-green light which is required for NBI, ICG or further advancements. If we talk about the light that we used in laparoscopy, I am personally fortunate that 10 years back when I was doing my MS, I was able to see those halogen lamps which used to produce a lot of heats, which used to have fans and everything. But now most of us, we are using xenon and LED. So two important characteristics are there in light sources. Number one is color temperature and second is intensity. So the color temperature, it is said that it should be on the higher side so that it mimics the light of the sun, that is we are most accentuated to, we are most habituated towards. If we see a white light or a little bit on a bluer side, we feel more comfortable. So there's a little bit controversy here. Some people say xenon gives a better light, LED gives a better light, but the reality is both of them are giving acceptable lights. The difference is the LED has very low maintenance and has a life of more than 10,000 hours. So that is why in most of the cases, LED is slowly being progressively more accepted. Second point here is the intensity. It should be minimum of 150 watts, maximum of 400 watts. If you have less than 150, the picture is going to be pale, it is going to be dull. More than 400 is going to produce glare. Between this range of 150 to 400 watts, the shutter and the iris, they are able to adjust the light. But if it is out of this field, it would be difficult for the image processors and the camera head. Third is light cables. Fiber optic cables are good enough. Most of us probably we are using fiber optic cables. They are durable. We cannot bend it beyond a point. Otherwise the fiber optic cables will break. But they are not as good as fluid light guide cable which has a fluid gel inside them. So that gives 30% more light and a more accurate color spectrum. But the point is they are very delicate. They break easily. And suppose if you are using fluid light guide cables in your OT setup, you need to have some spares always ready. Now, this is a topic which I have to accept on the outset only. I wouldn't be able to cover in a small presentation. Most of the telescopes that we are using are having Hopkins rod length system. And the difference between the different telescopes is the number of rod lengths which are present in that telescope. So actually they are not in reality different for an HD image output or a 4K image output. That is the work of the chip. But suppose if you are working on a 4K setup, if you are working on a superior setup, you need to have that superior quality of telescope which has higher number of rod lenses in it. So that is a small details that we have to go inside. It's not written just on the topmost part of the supplier, but you have to go deep into it when you are purchasing these telescopes. Now we are having chip on tip telescopes where the chip is present on the tip and you don't need these rod lenses in between. These are used in robotic and 3D scopes. And there's a lot of things that we have to go into, how the angles differ, how the field of vision can be increased with the help of angle. We most commonly use the 10 mm scopes because it is able to give out the light through the light source and it is able to connect sufficient light also. Then the depth of perception also they differ according to the sizes, optical axis and longitudinal axis. We're having newer telescopes which can bend, which are called fiber optic telescopes. So but mostly we need to know about the most common telescopes that we are using. Second is camera head. So camera head will be having two components here. First is the coupler which connects it to the telescope. The second is it has two lenses which focuses the image on the chips. Now chips are the retina of the imaging systems here. So when we focus, these two lens moves and they focus the image towards these chips. The chips can be CCD and CMOS. CCD was an older technology, but it used to give very good images with very low noise. CMOS is coming up and it is cheaper, it's easier to produce, and day by day the quality is increasing. The reason why this camera head prices are falling down is because the CMOS has come up. So another important point here is there are two kind of chips. One is single chip and one is 3 chip. So what happens is the primary colors are detected by a single chip. But in 3 chip, what happens? There is a prism which separate these lights into 3 primary colors, and all these primary colors are detected separately by 3 different chips. So what is the benefit of a 3 chip? The thing is, red is generally a overbearing color in these primary colors. So if you have lot of blood in your field, many of the systems you would have noticed the whole screen goes a little bit dark, and the color spectrum and the color differentiation is not that good when there's a lot of blood in the field. So that is a problem of single chip. Now in 3 chips, what happens is, because they separate these 3 colors, the chip which is receiving the red color can adjust and can bring the red color down, and these things, the primary colors, can be individually adjusted. So that is the reason if you have high quality chips and you have one chip on one side and 3 chips on the other side, the 3 chips is probably going to work better. Also in the camera we have shutter and iris. Now they regulate the amount of light which is going towards the chip. In today's date, generally most of these settings are on auto, and they are also present in the image processors. But yes, if you go into details, you can adjust those settings manually also. And these things matter when you are doing cystoscopy, hysteroscopy, and then you come to laparoscopy. For us, if you are doing regularly laparoscopic surgeries, so we don't need to change them that often. Image processor just converts the light into digital signals, and in today's era they have even the focus, field of view, and shutter speed, and all those things can be adjusted through image processors, and various processing for ICG, white balancing. Now white balancing is another concept I will not be going that deep into. So most of these things are being able to done at the image processor, and the newer image processors that are coming, they are having both light source and image processing in the same system which is available. Now lastly I would be coming to the monitor. The concept here is, we all are getting televisions for our houses, and we always select 4K, 8K, QLED, and the newer technologies. So the thing is, HD means around a number of pixels, 180, 4K means around 2000 into 3000 pixels. So they are just telling us the number of pixels. In this manner, mobiles are much better. They tell us the pixel density, and in actuality, pixel density is more important. So if you are having a 24 or a 23-inch monitor in your laparoscopy suite, HD is good enough, because we have never had a problem with HD when we have been using for a long time these 24-inch screens, and the image quality is good enough. It is smooth and details is perfect. But suppose if you want to hang a 55 or a 60-inch monitor, these pixels are less for that monitor. We have tried that approximately few months back in the same one of the meetings only. So what we saw that the image is very grainy, it moves very badly, and you cannot operate with that. So if you are planning to have a big screen like 55-inch or 60-inch, you need appropriate number of pixels for that. So then you need to get a 4K monitor. So there is the difference in that. So if you are getting a 4K monitor of 24-inch or 21-inch, it's not going to make that much of a difference. But what other difference is there other than that in a monitor which is there in our laparoscopy suite? So few things are very important. Other things are, you need to have a good frame rate. 50 is acceptable, that's present in all the monitors. You need to have more contrast, more than 1400 to 1, more luminance, more than 1000 nits, and more angle of view. We need to see them for all the angles, and again the response time should be less. For the gaming monitors which are coming for youngsters these days, if you play on a console, you need to see the effect on the screen as rapidly as possible. Same for us when we are doing laparoscopy. If you are moving our hands and if you feel that there is a perceptible lag there, that's not acceptable. That is why all these monitors have a low lag time, less response time. And also why these monitors are specifically from these medical brands, because these monitors you have a lot of number of outputs, and you can disassemble them, you can clean them, and they generally withstand processes like fumigation well. So that is why medical grade monitors are different. And lastly, newer technologies like OLED and other things are coming. They don't have good brightness. LCD works perfectly fine. That is why even if you see most of the good monitors are also LCDs.
Pratik, can you move
faster.
Yes, sir. This is my last slide and I'll be finishing after that. So lastly, I would not be going that deep into 3D technology, but it's different because there will be a chip on tip telescope, there will be a separate camera head, separate kind of processor, separate kind of screen, and then you have to wear polarized glasses to visualize those 3D technology to use it. The depth of perception is very great, very good, but most of the people are not very happy with this technology. What they have found, what we also have found in our institute, when we are using a 4K, if you are using a 4K camera and a 4K screen, the detail is so good that it actually provides an indirect depth also to the picture. It's very comfortable. And I would like to know if some of you are having a very good experience with 3D imaging. I understand it's too brief to include everything, but it would be brief. So in the last, I think if there are all of these factors are present in our laparoscopic suite, we need better integration, automation, and probably we need an integrated system which can have most of these qualities in itself, and it should be future proof. Because if the things are changing that rapidly, then the laparoscopic suite would require a lot of investments yearly. Thank you from the AIG team. Thank you.
Thank you, Pratik. So we'll have a next speaker, Dr. Raghuram from AIG. He will be presenting on ICG in surgery, technical tips. Dr. Raghuram, please.
Good afternoon, all seniors and my senior colleagues, and I thank for giving me this opportunity to speak. Dr. Pratik has elaborately he said that it's a brief presentation. It's been an elaborate presentation. My presentation is not going to be so elaborate. I'll be just sticking to the basics. So fluorescent imaging is an enhanced visualization technique for a better visualization of the structures and pathology during surgery. It has been evolving rapidly over a period of time and has been used in almost all disciplines since it's being used in retinal angiography some 50 years back. Now, near infrared imaging is the preferred technique compared to the ultrasound, ultraviolet rays or white light, because it has got better penetration, better noise to sound ratio, and the tissue doesn't have autofluorescence when you use near infrared fluorescence imaging. There are several fluorophores described at today. I'll be talking about the ICG indocyanine green, which we are routinely using. So in fact, if you go into the literature, there are a lot of NRF material which are used for sensing biological targets. Most of them are put into there are 4 types. In fact, the fluorescent dyes which we use, the cyanin dyes, squarin dyes, and all those things. And there are some quantum dots, also called as nanocrystals. The single wall nanotubules. The mechanism in which they produce the fluorescence is a bit complex, but the simple physics is that excited electrons, when they come back to the normal ground state, they produce protons, and that causes fluorescence. And so indocyanine green, if you go into the pharmacokinetics, it is a water-soluble tricarbocyanine dye with a molecular weight of around 700 Dalton, and it is a negatively charged particle which is quite soluble in water. And once it is injected into the intravascular compartment, it binds to the blood lipoproteins and it remains within the intravascular compartment. And it is selectively taken up by the hepatocytes, and there are a lot of molecules which and the hepatocyte and liver cells which take up the dye and which is transported into the hepatocyte and is transported into the bile duct. And these mechanisms are these alterations in the mechanism, in the molecular mechanisms, are important. And type of fluorescence which dye generate when we are seeing at the liver tumors, whether it's a partial fluorescence or total fluorescence or it is a rim enhancing type of fluorescence. And once they are taken up by the bile, the dye is completely excreted into the bile. Biliary excretion occurs up to 50 to 20 minutes and is an extremely small half-life of around 3 to 5 minutes. So it makes ideal for repeated applications. So the ICG gets excited at the excitation maximum wavelength is around 810 nanometers, and after that the fluorescence is more than 850 nanometers, that is in the infrared region. And the spectral stabilization occurs once the ICG in the water gets aggregated, aggregation of which depends upon the solubility concentration and also the time. the spectral stabilization, that is the aggregation, occurs faster in water, distilled water, rather than normal saline or albumin. That's why distilled water is recommended for dissolving the ICG, not albumin or normal saline. And there is the fluorescence intensity of the fluorescent. If you see the fluoropores, the concentration of the fluoropores in a solution can be measured by the intensity of the fluorescence, which is governed by a law called as Lambert-Beer's law. But as a fluorescence concentration of the ICG goes beyond 15 milligrams per liter in the plasma, it doesn't follow Lambert-Beer's law. Probably the concentration of the fluorescence will not follow with the concentration, linearly with the concentration. That's why even with the moderate concentration, maximum fluorescence can be generated. But to increase the fluorescence or to keep the fluorescence going, we have to give repeated injections. And fluorescence intensity peaks within around 30 to 45 seconds after injection, that which corresponds to the early arterial phase, and then declines within 2 minutes, that is in the venous phase. And that is the peak and washout dependent upon the circulatory status of the patient. That's why we have to keep a watch on the circulatory status. Morning we had some issues regarding the fluorescence, whether they are generally, it's probably because of the dose and probably because of the circulatory status of the patient. We had delay and rapid washout of the contrast of the fluorescence. And the decomposition of ICG occurs by producing a singlet oxygen species, but it is not toxic to the tissue because these oxygen reactive species are reabsorbed by the decomposed ICG. So the principles of fluorescence imaging, Dr. Pratik has spoken a lot about the cameras, types of cables and monitors and all those things. I just want to just briefly put in what is the principle of the fluorescence imaging. We have a light source. Light source contain all the wavelengths, including the excitation wavelengths and fluorescence wavelengths. So the light, when it passes it has to pass through the filters. These are called the high pass filters. The first type of filters, that these high pass filters observe the fluorescence and only allows the excitation wavelengths to reach the tissue. Once it reaches the tissue, that fluorescence is generated, and the fluorescence along with the excitation wavelengths, they pass through the filter. These are low pass filters. The second filters, these filter out the excitation wavelengths and allow only the fluorescence waves to reach the sensors. So when you look at the principles of fluorescence imaging, there we have a light source. Dr. Pratik has already spoken elaborately about the light source, type of light source. The most of the imaging systems now use a LED source. And if you are using diode lasers, then the filters are not required because the excitation wavelengths are mostly will be monochromatic. And there are two types of cameras, CCDs and CMOS cameras. Dr. Pratik has already spoken about these cameras, so I will not be talking much about these cameras. So we have various imaging systems which are available in the market, but almost all the current imaging systems have got certain limitations. I will be highlighting two of the most important limitations. One is most of the systems do not offer quantification tools. That is, by knowing the intensity of the fluorescence, we will not be able to differentiate the pathology. See, if you are seeing the sentinel lymph nodes, by knowing the intensity of the fluorescence, we will not be able to differentiate whether it is a pathological lymph node or if it's a normal lymph node, it's a normal tissue. That is one limitation. And another limitation of the current fluorescence imaging is simultaneous fluorescence imaging using various fluorophores. We come across in the pelvic surgeries, we want to see the ureter, we want to see the blood vessels, and we want to see the intestine. So because ICG is completely excreted into the bile, it will not be excreted by the kidneys, we will not be able to see the ureter. So we have to introduce ICG directly into the ureter. But if you use methylene blue along with the ICG, so we can differentiate the bowel, artery and ureter at the same go. It becomes less cumbersome. The systems now, what we are using, will not be able to visualize different fluorophores at the same time. This is what we are saying. Now that Olympus company has come with yellow light imaging, probably some of these technical difficulties will be overcome. And the next important thing is what is the dose, time, site of administration of the ICG, which we come across in our practice. And for this, I referred to a beautiful article where some 800 studies are looked into, out of which 171 studies are selected, excluding all the case reports and systematic reviews. And this study has put the usage of ICG into 4 clinical applications: sentinel lymph node mapping, tumor detection, tissue perfusion, and detection of the vital structures. So for sentinel lymph node mapping is not a standard of care still as it in GA malignancies, as it has happened already in the breast cancers and melanoma cancers. But with the advent of ICG, with more number of studies showing its advantage, now ICG is being routinely used for sentinel lymph node mapping. And if you go through the studies, the dosage for sentinel lymph node mapping has been very wide, from starting from 0.25 milligrams to 100 micrograms, 100 milligrams. But the recommended dosage for sentinel lymph node mapping is around 2.5 milligrams. And the route of administration is usually peritumoral, the same thing where we adopt the blue dye, which is injected around the tissues in the 4 quadrants of the tissues. And to improve the absorption, it's always minimal invasive techniques are better. Endoscopic application should be used, or a laparoscopic application. And most of the times, what is the timing? Most of the times we feel that maybe it's 24 hours or 6 hours before, but the study shows that just before starting the surgery, if you can apply the ICG, that will be sufficient. And the time to visualization of the sentinel lymph nodes will be around 50 to 30 minutes. And tumor imaging, where we are all interested in liver surgeries, particularly to differentiate between the metastasis and to see the metastasis and also the primary tumor. There are basically 3 types of images we get in the tumors, whether it is a complete fluorescence or it is a partial fluorescence or rim enhancing, depending upon various mechanisms, whether most of the times it will be the tumor will be compressing the bile duct, or it will be the changes in the molecular mechanisms where there will be absorption, but there will not be excretion into the bile duct. So for visualization of the tumor, the dose, particularly liver tumors, is around 10 milligrams, which is given intravenously 24 hours before surgery. And once the scope is introduced, we can directly see the images. And for peritoneal metastasis, the dose is again 0.25 milligrams per kg, which is given intravenously, and it can be given during surgery, and the visualization will be possible after 5 minutes. So they say that the studies have shown that if the peritoneal cancer index is more than 8, the applicability of the ICG fluorescence imaging is less. And for visualization, vital structures, bile duct is what we are interested in. So most of the times the dosage required is around 5 milligrams, which is administered intravenously. Most of the times we administer just before surgery, 1 hour before surgery, but the recommended time to properly visualize the bile ducts is around 3 to 7 hours before surgery. And for the perfusion, esophageal anastomosis and colorectal perfusions, we can use a dose of around 2.5 milligrams, which is administered intravenously, and the timing will be just before mobilization, and the fluorescence will be visible within 1 minute. And for liver segment, when you are doing liver surgeries, we want to visualize the exact line of demarcation. There are 2 techniques described, that direct perfusion and indirect perfusion. For both perfusion techniques, the dose is around 2.5 milligrams, and which can be directly given during surgery, and you can see the perfusion status within 2 minutes. So one thing we'll be worried about is about the adverse events of ICG, but research literature, there are not much toxic effects of the ICG. The reported incidences of adverse events is around 0.05%. Most of them include anaphylactic shock or some hypotension, tachycardia, or urticarial type things. This and cardiac arrest are rarely reported. And most of the cases, there will be some predisposing factors like drug allergy or severe asthma, shellfish allergy. And the mechanism of the side effects is basically the non-immunological histamine release. And in the literature, if you say the maximum dose which can be given is around 2 milligram per kg body weight. And this is a short video where how to administer the routine this thing which we have 25 milligram lipolyzed powder of the ICG, which is reconstituted with the distilled water, and it is injected into the vial through a filter which is a 0.2 micron filter. So once it is reconstituted, it is administered through the IV, and the time of administration, it has to be given a little bit slowly, and maybe over 2 to 3 minutes. And after giving the injection, flushing with saline is more important, because sometimes if it is not properly flushed, we will not be able to see the fluorescence properly. So the technical tricks I want to tell here is that the dye is non-toxic. It has a very short half-life, and we cannot increase the fluorescence by increasing the concentration. Only by repeat applications we can improve the visualization. And it emits good fluorescence at low doses, and duration of the fluorescence depends on the circulatory status. And imaging technology is rapidly evolving, and maybe we'll have one presentation how the technology is around. And dosing and timing depends upon the clinical application for which the ICG being used. Thank you.
Thank you, Raghuram. Any questions or clarifications? I have one thing, one more usefulness of ICG is thoracic duct visualization during esophageal surgery. And we have had experience wherein we have given the dye into the inguinal node 45 minutes to 1 hour before surgery, and there is excellent visualization of the thoracic duct in its entire course in when you do the thoracoscopic mobilization.
Yes, sir.
Any comments or questions? Another thing is in esophageal gastric conduits for esophageal surgery or following LPO, we have found that if after ICG you find the upper end of conduit is ischemic or less vascular, we have done supercharging using microvascular techniques before anastomosing to the pharynx. It's quite useful.
So if there are no comments, so can we move on to the next session, please? Thank you, Prateek, and thank you, Dr. Anand. So now, can I ask Dr. Rohit Dama to talk on fluorescence guided surgery panel discussion, esophageal surgery? Dr. Rohit. So, Dr. Rohit, you can ask the panelists, moderators to come.
Yes, sir. I think we have Dr. Ibrahullah and Dr. Kalyarasan for being the chairpersons come panelists. Thank you, sir. So I'm going to speak about ICG in esophageal surgery. And we know esophageal surgery has moved from thoracotomy to era of transhiatal esophagectomies, then transthoracic esophagectomy to now where we do thoracolaparoscopic esophagectomies. And minimally invasive surgery has taken over. Similarly, there is, as we discussed, there have been advancement in imagings. So, as sir was pointing out, in esophageal surgery, predominantly these 4 areas we've seen the help of fluorescence imaging. One, as we discussed, thoracic duct, it's very easy to identify, and once you identify, you can prevent injury, or if there is already a chylothorax, you can treat it. We'll show you some videos about that. And as we do for corrosive or even for carcinoma esophagus, when we have this colonic and gastric conduits in the neck, vascularity at the anastomosic site can be nicely checked with the ICG. Lymph node mapping is another area where radicality can be improved by injecting the peritumoral tissue. This is usually done the previous day. And also the upcoming role of sentinel node identification. There is one relatively less used where tracheal vascularity is checked after radical clearance of the nodes at the carina. So we all know chylothorax, a very morbid condition, and generally if it is post-surgical and for visualization, this is what we follow. Both sides in one lymph node are injected with 2 ml of ICG. This is done just
an hour before induction. So 1 hour before we start the surgery, a local massage, and I think in half an hour we can see the thoracic duct nicely lighting up. This is how we give the dye into the inguinal lymph nodes under ultrasound guidance. So this is a small video where we can already see the thoracic duct. So this obviously was a thin patient, and we can see the duct, the anatomy, it is between the arch of the aorta and the azygos. So suppose you are not using this, or for some reason the facility is not available, the landmark remains that the plane between the azygos and the arch of aorta and the aorta, that is where it lies. So with the white light, it is quite difficult to spot, but with the ICG mode, it is seen quite nicely. And we were actually injecting previous day, but we saw that washout was there, and so since then we've started injecting pre-operatively. So that's how you can see and probably prevent any injuries, especially if we know that the tumor is bulky in that area. We routinely use, at least for patients where we are doing esophagectomy for end-stage esophagus, where it's a dilated huge esophagus with difficult planes. So this is another place where we had used, this patient actually was planned for a esophagectomy, and it turned out to be quite a locally advanced tumor, and by the time we realized it was opened up, so the thoracic duct was very close and there was doubt of some extravasation, so that can be clipped. During laparoscopic transhiatal esophagectomy also, if you injected this, the thoracic duct, usually it is difficult to injure, but if the anatomy is bad, or if it's a lower third tumor which is badly stuck at the hiatus or G junction tumors, that can be a problem. So that also can be nicely visualized. So coming to the next use, the perfusion. Intravenously we need to give this, and with this give it on table. I think within 2 minutes we can see the flush and perfusion, and as we discussed, it can be very easily repeatedly given, the washout time being 2 to 3 minutes, and depending on what we find, the margins can be revised, or as Dr. Pratap Reddy sir was saying, we can supercharge your grafts. So there is a zone called opti zone. Now this is the optimally perfused zone which we see after ICG injection, and it says that the anastomotic results are likely to be good when the anastomosis is done at this opti zone. There's another 30-90 second rule where it says that the earlier that the dye or the flush can be seen, that means the organ that you are looking at is better perfused. There were studies in gastric pull-up for about 150 patients which showed lesser leaks in patients where ICG guidance was used. We had a study at our place in patients with corrosive injury, and out of 17 patients, 5 patients, there was hypoperfusion on ICG. 3 out of these 5 patients had a leak, including 1 patient which was extra picked up by ICG and not with naked eye. So this is the ileocolonic conduit. We use the right colon in corrosives of the esophagus and stomach injuries, and that's the ICG given, showing a bright green color, which means it is nicely perfused. This is when it is in the abdomen. We need to check again once you take it into the neck, because there can be twists and pulling of the vessels in the thorax. So once in the neck also, it can be repeated and checked again. So as we were saying, sometimes the dose insufficiency. So here ICG was given and it was slowly brightening up, and probably we see one sudden brighter. So this is probably when the dose was given, and since this was nightly perfumed, within 30 seconds it would light up. So this is another place where we used ICG. This was a leiomyoma in the infraazygous region where it was being enucleated. So it's a routine to do a check endoscopy to see the mucosal integrity after it is removed. So both blunt and sharp dissection we were able to enucleate. And since we had split the muscles at two separate places and there was doubt of vascularity, we gave ICG intravenous on table for this patient, and we did a on table endoscopy. So this light actually is from the endoscope, but the green image we are getting is from the thoracoscopic view. We can see the nice bulge of the mucosa. It is nicely perfused. There was no problem with the perfusion. The other thing it helped here was because of the splitting of the muscles at two places, it defined as the muscle edges for us, because we close this muscle layer over this intact mucosa. That's how ICG can be used in different situations. And we don't have much experience with this, but ICG in lymph nodes can be given usually previous day about 0.5 ml in 4 quadrants in the peritumoral area. And the next day when these patients are taken up for surgery and all these nodes that are lit up, they can be cleared and you can have a more radical clearance. We are doing a study of this, but that is for stomach cancers. In esophagus, we have not tried yet. There's an upcoming role for sentinel nodes being picked up after giving ICG on table. And to summarize, ICG has a good role, especially for thoracic duct identification, prevention and treatment of their injuries, tissue perfusion and checking the anastomotic size, lymph nodal mapping for sentinel and radical clearance. Thank you.
That's a nice coverage. Just wanted to ask you, would you recommend it as a routine use for every case or would be selective?
No, sir. Practically, we are also not doing for all cases. I mean, when we know the tumor is thin, it is not in that area. Most of the patients that we now use are post neoadjuvant. The tumor is shrunk by that time. But anywhere we have doubt, we use that. And as I said, we do quite a bit of numbers for end stage eclasia. In spite of POEM being a good option in this institute, so many patients who have this end stage eclasia or diverticular disease where you expect adhesions. And as I showed one patient for esophagectomy, we knew it was a bulky tumor. So those patients we use.
And for this conduit, gastric or colonic conduit?
We actually had a thesis going on for one of our D&D students. So, but that is, I think, almost all cases we are using that. Anastomosis checking.
Yeah, thank you, Dr. Rohit. Nice presentation. I have some comments just to add a few points, practical points to what you have added. So, of the indications which you have shown in esophageal surgery, the thoracic duct comes at the top. The reason, not primarily for identifying the thoracic duct, because with good imaging you can actually see the thoracic duct, but it's more useful when there are aberrant ducts. That's where actually the application really, because as we know that there are a good number of patients have aberrant ducts, and ICG really plays an important role there. With respect to the site of injection, as you rightly pointed out, the inguinal node, that gives a good visualization. We tried actually 3 methods. One is inguinal, second in the dorsum of foot. Compared these two, inguinal is better. That's one other technique. If you don't want ultrasound guided injection into the node, previous day you can actually inject into the subcutaneous space in the inguinal region, and then slowly it picks up, and by the time the next day the ICG does show. That's another technique which can be used. Regarding the lymph nodes, we tried giving submucosal injection the day before, and then also intraop there are actually no zeros, but you just inject into the muscularis layer. So we tried the two techniques. Unfortunately, in esophagus, the ICG is not very useful because it's a narrow space. The site where you inject the ICG, that surrounding area becomes brightly fluorescent. So it's not really helpful in identifying the nodes. And especially if you are trying the introp injection, if you spill the dye, like while injecting some spill happens and the whole area becomes fluorescent. And so it's some of the practical problems when we use for lymph node detection. So somehow we need to work out a way. So introp, now we don't use it. So try pre-op injection, and the dose has to be much lesser, not the 2.5, actually 1.25, because the moment you give slightly more dose, if that area becomes fluorescent, the whole field. And the third point, as you have, with respect to conduit, that's where the technology needs to improve, because right now whatever systems we have in laparoscopy, they just show okay the fluorescence. It's a subjective. We need objective parameters. Right now the only objective we have is the time taken for the fluorescence to appear, and also the time it takes for the disappear. The both are important, because when there's a venous congestion, the time to disappear also becomes important. But we need the software base, which are now there in some of the handheld open systems, which give objective cutoff values. I mean, it gives objective value, and then you come out with a cutoff. So we need, I think, similar technology in the laparoscopy also, laparoscopy systems.
Probably this system, I think, has somewhere.
I'm not sure about the present one, but
they can
still
quantify the brightness.
The Visera Li 2 does not have any of the software-based quantification. I'm not sure about the Li 3. What?
Thank you, sir. Thank you. Those were really useful things, especially the subcutaneous one, because we were behind a radiologist to come and inject. So maybe we can also try that. Thank you, sir.
Any? We have, I think, another 5 minutes. If any other questions, yes.
Yeah. So yeah. But with what we see day to day, like, yeah, because, yeah. Yeah, so we were using that same laparoscope when we did the study for our DNB guy, approximately 5 centimeter away when we keep, and no, it is almost like that is what was standardized in that study.
That's actually precisely what we are telling. So because right now what we are doing is subjective. So we need an objective, a software-based quantification. Only then we can actually compare. If you want to compare between two studies, then with the present technology, it's become more subjective and difficult to compare.
Yes. No.
Or are you going to just do peri-picking based on fluorescence?
No, sir. The idea is to do a clearance what we otherwise would have done without the ICG.
Is this the backup?
Yeah. So maybe something extra lights up, probably you need to take care of that.
Is there some data on how often it does?
So I think the main...
In esophagus, that is.
No, sir. I am not aware of.
No, the main role of a proposed role in esophageal cancer is to detect RLN nodes, because that's where there are some school of thought like you can avoid selectively RLN node dissection if it is not involved, because that's where the morbidity increases. But at least whatever cases we tried, somehow it is not that helpful in esophagus. That's because you have tumor in the mid thoracic, so that's where you want to be, you want to know whether the RL nodes involved or not. But moment the ICG is injected there, you will have actually fluorescence in the surrounding tissue also. The other problem also is because why we need objective is because most of the experience comes with robotic. In robotic, actually you can adjust the intensity.
Yeah.
You can increase or decrease the intensity. Now, so what intensity level you are going to standardize, and how you are going to compare. That's also an issue. So we need an objective method to evaluate.
Thank you, sir.
Thank you.
There is one software-based objective evidence evaluation of this, which lights up just something like what the battery charger we see in the mobile. It just shows us the amount of intensity, but it does not say that it's absolutely, it have been absolutely quantified. It just shows how much intensity of the color, not the quantification.
They mark point A, point B on the conduit, and then they calculate the rate of flow.
Yeah, that's a velocity. I think that some 1.5 centimeter per second is considered as a rap. Slow speed 3.5 centimeter.
Those studies are there.
Yeah.
Unfortunately, that's not available commercially as well.
Thank you so much, Rohidama sir, for that wonderful presentation. Very good videos, and thank you to the panelists also. For the next session, I would like to invite Dr. Sanjeev Haribhakti sir, and he would be presenting on fluorescence guided gastric surgery. For the panelists, I would like to invite Dr. Sujay Paul sir and Dr. DVL Narayan Rao sir.
Good afternoon, everyone. Firstly, I must disclose here that I don't have personal experience on this subject. We have been doing fluorescence guided surgeries mainly for colorectals and for biliary tract. When this topic was given to me, I thought I'll see how much literature is there, and to my surprise, there was quite a bit of literature in the last couple of years. So I'm going to summarize the literature for you in this field. I'll start with some aspects of benign gastric surgery and then talk about the more commonly used technology for gastric cancer. So in the benign gastric surgery, the main role is to assess the vascularity, mainly in Reed-Neeson's fundoplication, and there are paper where they have used it in children to avoid perforations and to delineate the tissue anatomy. In Heller's procedure, people have used it to identify the residual muscle fibers in few of the articles published. However, it has not been standardized. In gastric volvulus and large paraesophageal hernias to assess for the vascularity of the stomach, it has been used. In gastric devascularization to look for the gastric collaterals, intramucosal and submucosal collaterals, and to check for intraoperative staple line leaks in bariatric surgery. There have been a few case reports. Gastric surgery for corrosives to look for the conduits, and to check for the resection margins in EMR and ESD for polyps and tumors. So these are some of the areas, especially laparoscopic redo-Neeson's. It appears to be a good technique because the most significant risk factors are unsuspected perforations. When we have to do the dissection, there are a lot of adhesions over here, and we have dismantled the previous wrap, and there is a risk of sometimes perforations and bleeding. Apart from that, risk of pneumothorax and adjacent organ injury. So here one can use, especially to assess for the anomalous left gastric artery, or these are the areas where the fluorescence can be seen, and ICG guided surgery can be useful. But the main role of fluorescence guided gastric surgery is for gastric cancers. It has been used in both early and in the advanced cancers, predominantly for endoscopic tumor marking for tumor location during surgery. But the major role of fluorescence in gastric cancer surgery is for sentinel node navigation surgery. And this is one area where there has been a large number of papers, some of the good randomized trials also reported from Korea and China, and I'm going to review this literature for you. And then there is this field of lymph node mapping as a guide to D1 plus or D2 dissections, where minimum we need to remove at least 16 nodes and preferably up to 30 lymph nodes. So this how this technology can guide us to select what kind of resection to use. anastomotic perfusions to prevent leaks. Perigastric vessel navigation is another field that I'm going to allude to in the presentation. Gastric conduit vascularity, as has been shown, and for early gastric cancers, when to look for resection margins where we do an endoscopic submucosal or full thickness resections. And there is some emerging role of peritoneal carcinomatosis also. Coming to this Senorita trial, which has been published from Korea, it's a sentinel node oriented tailored approach for gastric cancer. They published their short-term outcomes in BJS 2020 and subsequently their 3-year survival data of the Senorita trial. And in this trial, 580 patients were randomized, and these were all early gastric cancers, T1 and 0 tumors less than 3 centimeters. And they were compared the results of laparoscopic stomach preserving sentinel lymph node basin dissection versus laparoscopic standard gastrectomy after injection of human serum albumin and ICG both. And albumin was labeled with technetium-99. So this was the dual fluoromarkers. And the trial also performed intraoperative pathological examination, including IHC and molecular biological techniques for detecting their metastatic lymph nodes. The results from this large trial suggested that the dual tracer method was superior to ICG alone for successful laparoscopic sentinel node navigation. And the 30-day complication rate was similar in both the groups, and the 3-year overalls and 3-year disease-specific survival were also comparable in both the groups. And they suggested that there is an important role of sentinel node navigation surgery in clinical practice. This was the another trial, which was a randomized trial from China, which was published in 2020 again, and this was for more advanced tumors, all the resectable tumors, clinical stage T1 to T4, NO, N+, which were all resectable tumors were enrolled in the study, and they were randomly assigned to ICG versus the non-ICG group. So these patients, there were, I think, 266 patients, 133 in each arm, and they underwent laparoscopic gastrectomy with NIR ICG, and these patients had, the patients who had ICG had an endoscopic injection 1 day prior to surgery. The main outcome was the number of lymph nodes retrieved, and they found that the mean number of lymph nodes retrieved in the ICG group was significantly higher than the mean number of lymph nodes retrieved in the non-ICG group, and there was no statistical difference between the severity of complications within 30 days. So they concluded that ICG can noticeably improve the number of lymph node dissection and reduce lymph node non-compliance without increased complications in patients undergoing D2 lymphadenectomies, and it can be used for lymph node mapping as well. So there was a paper on this, a criticism and a comment by one of our Indian authors on this paper, and this was from the our Indo-American group, where they published a letter to the editor, and they showed that they suggested that the high rate of non-compliance essentially means non-removal of nodes which were intended to be removed for completion of D2 dissection, and this leads to dilution of the procedure, and non-compliance rate was lower in the ICG arm. They also showed that the rate of non-compliance can be reduced only by stringent protocol enforcement and adhering surgeons adhere to set guidelines to remove the intended nodes rather than doing it on the basis of ICG. And they said that the sensitivity of 56% and specificity of 46%, in a large robust, further calls for further refinement in the techniques. And this is one of the strictest, criticisms of this study and many other studies where the false negative rates are quite high. And many of the demographic parameters were unequally distributed in the study. So there is a subsequent, that was a FUGIS 012 trial, and there subsequently a FUGIS 019 trial based on the same protocol was published, which compared the subserosal and the submucosal injection techniques of ICG. This was also from the same center in China, and the endoscopic injection was 1 day prior, whereas the subserosal was 20 minutes prior to the surgery, and the D2 stations luminance were compared, and in both the groups there was no difference in the number of nodes removed, or there was no difference in the the compliance rates. It was similar, and that's why they concluded that both the methods are good enough. Either it is subserosal or submucosal injections But from the point of view of, they said, patient satisfaction and cost effectiveness, they favored the subserosal route of administration. Zong, they pooled the data from both these randomized trials and confirmed that the higher number of lymph nodes retrieved and reduction in the non-compliance rates of D2 lymphadenectomies using ICG. And they said that even for early tumors, the sensitivity was quite high. So they concluded that, this could come under current practice, clinical practice guidelines also. Interestingly, the reported metastasis rates for stations 14V10 were higher than previously reported, reinforcing that there is a role of image-guided lymphadenectomy in gastric cancers. But there are some drawbacks of this approach, the sentinel node navigation surgery, and the two biggest drawbacks are false negatives and skip metastasis. False negatives are still quite high, ranging between 23 to 60%, and there has to be an improvement in the technique to improve this false negative rates. In spite of malignancy being there, it was not detected on the ICG. And the other is a skip metastasis, and this skip metastasis happens because of the blocked lymphatics. Normally, the concept is that the sentinel node is the first node to be affected, and then only the next level of nodes should be affected. But sometimes it can happen that the sentinel node may be negative, and there could be a skip metastasis to the second or the third echelon group of lymph nodes, and the reported incidence is about 11%. The next area is the perigastric vessel navigation. So they found that a presence of infrapyloric artery, which needed to be spared during a pylorus preserving gastrectomy, or an accessory splenic artery which was arising from the left gastroepiploic artery, needed to be spared to prevent inferior polar infarction of the spleen, and this could be well identified based on ICG. So sometimes this kind of ICG can be used for preventing injury to these vessels. Even for detecting accessory left hepatic artery, there was a study, retrospective study of 31 patients, and they could detect accessory left hepatic artery in almost all patients. Not only that, based on that, they, based on the fluorescence of the liver, they tried to ligate hepatic artery in 20 patients and preserved in 10 patients, and found that there were no differences in outcomes, and they felt that authors concluded that ICG could be used in this to identify the accessory left hepatic artery, not only to potentially avoid injury, but even to ligate them based on the vascularity of the liver. So what is the future? Future, as we discussed, we need better quantification of fluorescence. So far, we don't have it. Only few case studies or case trials have shown this. It is not in clinical practice. And we need to have better studies to detect peritoneal carcinomatosis. And in the near future, it may be possible to perform personalized dissections based on individual drainage patients, rather than doing D2 for all patients or D1 plus for all patients. We could personalize their based on their ICG lymph node mapping. The future is to use ICG to be offered along with other modalities like hyperspectral imaging or confocal laser microscopy. Hyperspectral imaging is a method for analysis of the tissue's chemical properties to detect early mucosal lesions, to measure anastomotic perfusion, and to assess the resection margins. Whereas the confocal laser endomicroscopy, it shows it's an optical imaging modality that provides an in vivo histopathological assessment of the mucosa. So to conclude, with relatively no collateral effects or major side effects, and no significant compromise of operating times, ICG fluorescence applications are definitely carving a role in gastric resections, and they'll be playing an increasing role in the future. For sentinel lymph node mapping, ICG guidance is still in a very preliminary phase, but definitely there will be a role in gastric cancer, and the steps are being taken to invest in the concept of basin dissection instead of node picking, collecting more nodes to reduce the risk of false negatives, and develop more precise techniques for intraoperative pathological examination also. Finally, surgeons can assess the completeness of D1, D1 plus or D2, define boundaries of dissection, and this can also help in training for surgeons to perform minimal access and to retrieve enough nodes and perform adequate lymph node dissections. So the use of ICG could also lead to less extended tissue sparing surgeries for early gastric cancers, and to assess their nodal status and detecting micrometastasis, thus even allowing a new adjuvant treatment protocol. So these are some of the potential advantages or benefits that ICG can give us in the near future. Thank you very much.
Thank you, Dr. Haribhakti, for giving an extensive review of this nascent subject. It is still developing, as is very clear from the review that you have mentioned. There are two things that I wanted to highlight. One was the combined use of endoscopic and laparoscopic access for early gastric cancer, which the Koreans and the Japanese have tried to show that the image-guided surgery using ICG can help in the sentinel node detection, as well as combining the gastric preserving surgery with targeted lymph node excision. But there has also been at the same time realization that the sensitivity and specificity is not as high when we are looking at locally advanced cancers, gastric cancers. It may be relatively higher in the early gastric cancer and the intermediate types, but not in the advanced. So with those few comments, I would like my fellow panelists to address the issue, and then we'll ask the audience to contribute.
We also don't have personal experience in all these things. Hopefully all these meets definitely encourage the people to do more number of Indian studies will come up, not only ICG, other types of fluorophores, whatever are being used, even experimental, not even in humans also will come up. And hopefully Indian scientists also will and Indian surgeons also will take interest in these things. And obviously the Indian studies also might be more useful for us and for our younger generation. It should give directions to younger generation, I hope. Thank you.
So currently, from the two divergent aspects, the early gastric cancers and the more advanced gastric cancers, it appears that ICG based or lymph node, sentinel lymph node mapping is more important for the early gastric cancers to pursue an approach of organ sparing surgeries or selected lymphadenectomies rather than advanced gastric cancers, because of the risk of false negatives is still very high in advanced gastric cancer, and that's why I still feel that that is still a very experimental at a very early stage. Shailesh is here. Probably Shailesh can answer whether they have any experience at the Tata. Yeah, Shailesh, please go ahead, give your experience.
To be honest, we would really not. We don't have first-hand experience enough to be able to speak on such an aspect or such an issue. We would largely depend on our endoscopists, and then beyond that, what we are usually doing as standard practice. We have not really found a way where we genuinely believe that in our practice we have cases to the effect that something like this would be truly utilized. Even now in Tata, despite 230, 250 gastric cancer resections every year.
So that sums up actually what is the current scenario of this technology in gastric cancer. But what about Shailesh? What about in the future? What do you see a role of this technology in the future?
Oh, I think it's going to have a role, but it's going to be complementary. We heard some time ago Dr. Ramesh talking about it. I don't think this is something which is going to guide and make us, technology should not blind us and should not make us dumber. So I think the basic principles, quality of surgery, and the way we approach today in the pre-ICG era must continue in a very solid way. And then there would be a few situations which we will test, evaluate, and know over a period of time, where we will say that it's going to be absolutely invaluable and going to make a real difference either to the surgeon or to patient outcomes. That we don't know. We have a good toy with us. We need to test it very critically without ignoring some of the basics on which we are all trained.
So currently our approach that we do either a D2 or a D1 alpha for most, do you think it's the right approach? Because with this ICG experience, they have showed that say 14B lymph node or 13 or the number 10 station, they are much higher than what are previously reported. So if you use an imaging enhancement, would you be better able to judge whether you want to really go for D2 or D1 alpha? You can choose between the two for a particular patient, do you think?
So to be honest, at a very practical level, we have long moved away from D1 alpha and it's only D2. We are currently running a trial which is a D2 versus D3. We also know that the quality of radiology and radiology assessment not just by the radiologists, but in our dedicated clinic with the surgeons themselves, we would vastly be very comfortable in terms of mapping of all lymph nodes, not just the T2 basin, but even beyond. So this is because that's the way we have been trained in our own way, in our environment.
So maybe this image guidance can help you to detect whether there is lymph nodes beyond the D2 basin.
Yeah, this is possible, but if you have lymph nodes which are beyond this basin, in
You're
an
new
era where predominantly everything is neoadjuvant chemo, especially for anything more than T2 and above, we would be getting these lymph nodes out irrespective. So I would need an objective study where we can look at something like ICG beyond the D2 basin in a patient where the CT scan is not guiding us. The intraoperative resection is committed and done, and then the ICG is showing me the light up at a distant site, which might make it M1 disease in a patient who has got neoadjuvant. And then the question to be asked is, yes, it has guided me to that lymph node to get it out. What's the relevance of that? I would not know. So that kind of a study needs to be designed in order to truly utilize the full potential of this good technology, if I want to be very critical and scientific about this.
Dr. Sujay, do you have any?
I would rather want Dr. Pradeep, Dr.
Kalai.
Koval, if they have any comments to make.
Yeah, please.
I think the point that Dr. Shailesh was mentioning, because we actually precisely did a study, because we thought there's no role for central in our setup because we all get advanced gastric cancers. So we thought in what proportion of patients there is actually lymph nodes beyond standard T2. Unfortunately, we had 22 patients, a part of thesis, MCT. So we had 22 patients. Actually, we could identify lymph nodes beyond D2 in only one patient. The main reason is the moment you have a big node, which is involved node, the ICG rarely crosses that.
Sorry?
The ICG rarely crosses that lymph node.
Right.
So it gets stuck in that bigger lymph nodes. So at least in that small series which we have done, it is not useful to pick nodes beyond D2. I think that's our experience with it.
And there is a high false negative rate described in the literature also.
Any literature, Sanjeev, regarding the extent of resection in the stomach, especially in patients where there is a submucosal spread?
So resection margins have been checked. There have been some reports, but mainly for endoscopic resections, because for surgical resections, mostly we take about a 5 centimeter margin, and generally people have not checked for the margins by this technology, and it's more useful for knowing the vascularity for creating the anastomosis. That is the main purpose of this technology.
I think in our country, when we have more advanced gastric cancer, you did allude to peritoneal carcinomatosis, but probably that is an aspect which we need to look into more detail. For that, we probably need to give dye maybe a day before, 24 hours before, and then try to find out if there are peritoneal carcinomatosis, and then design treatment according to that. Because we are now able to treat one peritoneal carcinomatosis with HIPAC treatment.
Yes.
So that is something I think which we need to look into.
So this is a area of intense investigation. Currently, there are some ongoing trials. There is one Senorita 2 trial going on. There is a trial for peritoneal carcinomatosis using dual fluorospheres, because ICG has also limitation in this area. So they are either amplifying the RNA or using RT-PCR techniques to increase the yield of peritoneal carcinomatosis. So there is intense research going on in this area. There are some ongoing trials.
It's also stated that mucinous malignancies, mucinous adenocarcinomas, the pickup rates of peritoneal deposits are lesser with the ICG systems. So that's another pitfall. If there are no further comments, then I think I'll thank Dr. Sanjeev for the excellent presentation and thank my colleague for the panel.
Thank you.
Thanks to the management.
Thank you so much, Sanjeev Haribhakti sir, the panelists and everyone for such a wonderful discussion and such a good, thorough discussion of the literature. Next, I would like to invite Dr. Sadiq Sikora sir for fluorescence guided imaging in biliary surgeries. And for the panelists, I would like to invite Dr. Deep Goyal sir. Yes. And Dr. Mahesh G. Sethi sir.
Good afternoon. Thank you very much, and congratulations to GV and AIG team to get together all the people, and let's see how this new technology helps us in various facets of surgery. And we've already seen how exciting it is. One of the most common places which this has been used is in biliary surgery. So I'll just delve into its role most commonly for gallbladder surgery, and then its extended applications, and with the help of the panelists Deep and Mahesh. Piyush is not here. So actually biliary surgery has seen a great impact of ICG fluorescence cholangiography, and in HPB surgery overall, with the advent of its impact on biliary surgery, it has made tremendous inroads on that. Most commonly, we have used it in cholecystectomy to define the extrahepatic biliary anatomy, and we have come to a stage where we can say that it is safe, it is reasonably accurate, and it can improve upon the traditional methods which we use for defining the biliary anatomy. Most recently, this is in 2020, a multi-society practice guidelines was posed this question that what is the role of fluorescence cholangiography with respect to intraoperative cholangiogram? And the answer of the experts was that we don't have enough evidence for that. The next question was, should it be used along with white light imaging as opposed to only white light imaging? And the inference or the conclusion was that it may be a good adjunct to just white light imaging in order to define the extrahepatic biliary anatomy. But we have come a long way since then, and a lot of water has flowed under the bridge. And this contemporary series, the title paves the way for what to expect in this ICG fluorescence technology, lighting the way. And this contemporary series of 800 cholecystectomies from a single center demonstrated that there were no bile duct injury, every parameter was better, and they suggested that it should be a standard of care. We know that how this looks, it's interesting, and it defines the anatomy quite well. Even when it is obvious, it reassures us how good it is. It is easy to do. There is a very steep learning curve. The main key factor is how good is the bile duct to liver ratio of fluorescence. The higher this bile duct to liver ratio is, the better the visualization. And as you can see in this lower panel, this beautiful parallel cystic duct which runs, which can be clearly delineated by use of this fluorescence cholangiography. And when you look at images of cholecystectomy, you can see gallbladder, cystic duct, bile duct, all these common hepatic duct can be delineated quite clearly before dissection and after dissection. In general, we have seen, and it has been demonstrated, that cystic duct and common bile duct are the two main structures which are demonstrated by use of fluorescent cholangiography. The other structures, up to tune of 70%, you can see the common hepatic duct and the junction of cystic duct with common hepatic duct. And this is a universal experience in most series which are presented. Another interesting method of doing a cholangiography is direct cholangiography. And the benefit of this is that there is a high bile duct to, as a matter of fact, zero liver fluorescence. The problem is, if there is a spillage, it will stain all the tissues around, and fluorescence will mask the extrahepatic biliary system. And if there is a blockage of the cystic duct, then this method may not work as best. So one of these case control studies showed that IV versus direct cholangiography showed both the cystic duct and bile duct quite well, but reiterated the fact that the ratio or the fluorescence ratio is much better in this, thereby delineating the structures more clearly. So what is the evidence which is available at present with us? So there is this high level evidence of a randomized control trial. The first one is a classic trial which is quoted international randomized control trial of 300 patients in each group, wherein the purpose was to define the extrahepatic biliary anatomy in white light and in fluorescence cholangiography. And in all aspects, pre and post dissection, this was better delineated by fluorescence cholangiography. And subsequent trials also showed the same, even in a pediatric population. There are two, one systematic review and randomized trial comparing intraop cholangiogram versus the fluorescence cholangiography, and it showed that good delineation of anatomy as well as in intraoperative cholangiogram. There is also more literature since then. A lot of systematic reviews and meta-analysis have accumulated, most recently as in 2022 with 22 studies, more than 3,000 patients, and all of these highlighted the fact that it is safe, it is feasible, it is better visualization of extrahepatic biliary structures, and also a lot of these concluded that there is less conversion rate, less operative time, and even a less incidence of bile duct injury. The most latest international Delphi survey done by 22 surgeons who were given this they were called for this survey. The consensus was that fluorescence cholangiography is excellent in terms of delineation of anatomy. It prevents or minimizes the risks, and it has several advantages over intraop cholangiogram. One of the important things which was mentioned by the experts in the discussion was that actually the dose and timing is dependent on the type of camera systems that you use, which we often forget what we are using in each scenario and try to compare one with another. And perhaps that may be also something to look at when we are looking at the results of delineation of the anatomy by use of fluorescence cholangiography. Another one area of no consensus in this was the timing, optimum timing of administration of ICG and also the dosage, which as we saw since morning, that in most scenarios, that is one of the issues which has been raised. So what is the optimum timing in biliary surgery? So at least in cholecystectomy, there are some recent trials which have shown, which have compared that 30 minutes at induction of anesthesia, before, that is 2 to 6 hours before, or more than 6 hours before the surgery. When you look at these timings and dosages of 2.5 milligram or body weight based, it was seen that best visualization of cystic duct and bile duct is with 2.5 milligram administration at 2 to 6 hours. Another study looked at the doses of ICG with respect to 0.025, 0.1, 0.25 and 2.5 milligram at 30-minute administration, and surprisingly in this a low dose of 0.1 milligram seemed to delineate the structures much better than other dosages. So overall there is no consensus, and generally most people recommend using 5 milligram at about 3 to 7 hours or 2 to 6 hours prior to cholecystectomy, and that has been followed generally by most people. Now in certain other situations like acute cholecystitis and all, again this may be of great use because the risk of injury is significant in this, and here you can see that in acute cholecystitis, in one of the situations you can see fluorescence in the duodenum and you can see the bile duct, at least the common bile duct in this, and after dissection in this the structures are more clearly delineated, and post dissection once you do here is a post dissection. Having done the dissection, you can see that the cystic duct can now be seen and appreciated separately. Earlier as it was blocked, as it is acute cholecystitis, now you can appreciate that and you can do a clear dissection, identify the cystic duct and clip it. So we did a study about 62 patients of
I would think that one should use it regularly because it takes some time for you to master the interpretation of it. It's not that if you use selectively, then you are likely to miss things. It doesn't help. And normally in our institute, what we do is 30 minutes prior to the surgery, it's 2 to 3 milligrams. And we are able to see the anatomy very clearly once the scope is inside. But let me also confess that we are not using it regularly.
I would prefer to use it on a regular basis, even though we are not doing it as of now, because the incidence of bile duct injury has many times come out in patients who had a cleaner anatomy rather than a difficult gallbladder anatomy. So we need to use it regularly. We use at a dose of 0.1 to 0.2 milligram per kg body weight. As you alluded in your presentation, the fluorescence between the liver and bile duct, if we give the dye 2.5 or to 3 hours prior to surgery, we see that the liver fluorescence is come down and that the bile duct is enhancing much more better. Around 2.5 to 3 hours is what we prefer to give prior to surgery.
So, I mean, I agree with all your comments. We have not seen good fluorescence at 30 minutes or giving it early. I wonder whether it is a difference of the system that we use.
At what dose you used?
We use about 2.5 milligram.
That's what we also use, yeah.
The other thing is, I want to reiterate one of the comments made by, I think, for gastric surgery, which Shailesh made, and it's equally true for biliary surgery or cholecystectomy, that the basic tenets of cholecystectomy cannot be, waved away just because we are using fluorescent cholangiography in order to delineate the biliary system. So that has to remain the same. I wonder how many would prefer using it selectively or routinely. Yes, sir. Yes.
Able to visualize the bile duct and the biliary anatomy much better. The 4 to 6 hours better. Otherwise, and in 10%, in spite of everything, you may not visualize thing because the tissues probably.
You're talking about acute or in all?
Acute, in acute.
In acute.
We've used
Yes.
in all,
Yes.
but in acute, yes, because of the thickened tissues.
Ramesh, you wanted?
Thing about selective use, if you have to give it 4 hours before or 3 hours before, and then you really in a hole, once you do the laparoscopy, then when you just turn around and give the injection and hope that something is seen, is there something missing somewhere?
So when I said
if I do it in a contracted gallbladder, and that is the worst scenario, it's even worse than acute cholecystitis, where you can decompress the gallbladder and gain some space, dissect. The contracted gallbladder, I think it can be made routine practice, 4 hours before, 3 hours before. But in other cases, my biggest philosophical problem is, what do I do when I really find I can't make headway with the anatomy? And is there a way around it?
So when I say selective, that means we generally would like to do an acute cholecystitis. So you know that this patient is scheduled for surgery and you can give about 3 hours prior to surgery or 3 or 4 hours, which is what we generally do. Sometimes we are able to make out there is going to be a difficult gallbladder, as you said, in scenarios where it is contracted, recurrent episodes, and these patients, you would give it 3 to 4 hours prior to surgery when they admit. When you need it on the table, the only way out is you take recourse to the fact that there are some situations in which, or there is evidence that even 15 to 20 minutes prior to after administration, you may be able to visualize, and you attempt to see whether you will be able to visualize that or not. And alternatively, direct puncture if it is possible, but in those scenarios, it may not be possible because the gallbladder may be contracted, there is not much space and all. So, routinely may be best, but if you are not able to, at least in selective, these difficult situations, it may be of value at least to identify the biliary anatomy.
Sadiq, if I can make a comment, you see, most of the studies,
yeah.
the older studies are saying 4 to 6 hours before the surgery, and more recent studies are saying at induction or 30 minutes before the surgery.
I know, Deep, I don't know how it changes, whether it is the systems which have changed, whether it is the way we look at it, because honestly, we have not been able to visualize it, giving it early most of the time. Yes.
So we had done a study of 1 hour before and 4 to 6 hours before. And though that has not been published, but we found that with a earlier injection, the liver was much less, and that's why the visualization of the bile duct was much better. But the problem is the earlier injection is that these patients are admitted just 3 hours before. They are in the ward, and we would prefer to give an ICG in the recovery room because there are chances that rarely there can be anaphylactic reactions which have been reported. And that's why, we don't want to give it in the ward for a thing like this innocuous. So these are all the logistic issues that we face for giving an earlier injection. And that's why the best time is maybe get the patient in the recovery room about an hour before and give it there in the recovery room.
So we do give it in the ward, and I think there's very little evidence.
Do you give a test dose before giving?
Yes. Yes, Anthil.
We give it, use it selectively. One more important thing is impacted cystic duct neck stone as well as cystic duct stone. That's one area which is really helping us because we can identify the cystic duct bile duct junction, confidently say how far we can go. The laparoscopy has turned the attention from the bile duct junction to the cystic duct infundibulum junction. Beyond the infundibulum, this has given a little more courage to go into deep inside the cystic duct, a little more distance we can travel.
I mean, you can go and excise the complete cystic duct if the stone is impacted there.
It's little bit more. We can look out. That
Because of the delineation, yes.
And what we have seen, both in liver surgery as well as in biliary surgery, is the more we delay, or in the sense more duration is given, as far as injection is concerned, injected, the bile duct, the ICG stays in the bile duct for a long time. Why I say is, in transplant surgeries, when we give at the time of hemiaportic clamping, after 3 to 4 hours, it still stays when we go for the bile duct division. So it's better that we delay, in the sense, give early rather than at the time of induction. Delineation.
Yeah.
And the last comment is, in the inflamed situations, we need to take the camera so close to the hepatoduodenal ligament to visualize. Probably those 10% of patients whom we could not able to identify, at least one set of structures which you have pointed out, probably is because the camera is little far, little bit of dissection in and around the hepatoduodenal ligament. Inflamed tissues, fat can be a little bit mobilized to see the structure.
Yeah, that's our experience also in this.
That's because the depth penetration of ICG is very limited,
Very
around
limited.
0.5 centimeter, maximum 1 centimeter. So you need to dissect a little bit to see the fluorescence.
Just one come because regarding the timing again. So because actually we use in this bile duct preserving pancreatic resection chronic pancreatitis, we give a day before. So we give almost 12 to 16 hours. So even that time actually the bile duct is well visualized. In fact, bile duct much better visualized than giving either even 4 to 6 hours. So which means then when we actually review the literature, 18 to 24 hours, till the time the ICG will be within the bile duct. So most of the studies which tell about 30 to 60 minutes, mainly because of the logistics. If the patient is admitted day before, actually if you give the day before, you'll have much better bile duct liver contrast compared to any of those.
But for cholecystectomy, logistically, that's a problem.
I think that is the main.
Let me just end this with some interesting scenarios where it can be used beyond cholecystectomy, and then I will ask you all to comment where you have used. One of the situations is liver cyst deroofing, and in that situation, sometimes there is bile leak or injury to the bile ductules and that, and your usage of ICG cholangiography would help us delineate that. And as a matter of fact, this paper showed that there was also leakage which could be controlled. So this is one scenario which it can be used. As Kalai was saying, duodenum preserving and head preserving resection, you can identify the vascularity. So immediate administration can tell you about the pancreatic or duodenal arcade and vessels, and then subsequent you've administered the ICG earlier also, so that you can identify the bile duct also. So both these things can be evaluated. And this is another interesting thing which I found that direct injection during polydocal cyst excision, especially in patients with having a abnormal pancreaticobiliary ductal union, especially the PB type, wherein the pancreatic duct is opening into the bile duct. So if you inject directly, you should be able to see while dissecting the pancreatic duct in this, and then avoid injury to that or transect it at that point. And finally, one other interesting thing is to assess leak during following anastomosis which you have conducted, like a hepaticogynostomy. So on-table assessment of leak, and this is one paper in pancreaticoduodenectomy, post-pancreatic duodenectomy. It has been used to see whether there is free flow of fluorescence across the anastomosis without any leak. What are any other thoughts on its usage in biliary surgery?
No, I think what the way we are moving now is that I think we are going to be technology dependent as far as ICG is concerned. It's going to be like a Google map. Even though you know what to do and which route to take, but you are so sort of hung up on the technology that you're going to use it more often.
Mahesh?
Have used in hydrated cyst for looking
Yes.
at biliary
Yeah.
leaks.
Think.
And it's very useful. It does show.
I think that's another good usage of ICG. Yes.
So that we can identify. HA leak is one area where we can find out is there a leak. Other thing is to identify biliary system with this system so that we can target where to open it.
I think with robotic, it's become more usage in, because I couldn't come across very many articles talking about biliary stricture and usage of this. So in robotic, I think with Firefly easily available in that, this is and repair of bile duct strictures by robotic.
I think Sadiq will close the session as I'm getting signal from Dr. Rao.
Thank you. Thank you very much.
Thank you.
Thank you very much.
Thank you so much, sir, for the discussion was very comprehensive and it covered everything. Thank you so much for the panelists. So next I would like to invite Dr. Biju, sir, and he'll be talking about image guided surgery in liver surgery. And as panelists, I would like to invite Dr. Rajan Saxena, sir, Dr. P. Balachandran, sir, and Dr. R. A. Shastri, sir.
Thanks to all esteemed panelists, and with previous permission from the organizers, I'll just talk on enhanced image guided liver surgery. So what exactly we do, whether it is ICG or other techniques, we acquire imaging through various machines and processing the algorithm, creation of smart images, and transferring these images to the operative field. That's what we do. What is going to come is these techniques are going to come in the instruments what we are going to use. So soon the big robotic machines and big machines are going to disappear. So use of contrast dye is, this is the proper perspective of where we are standing, and contrast dye is in the middle part actually. So the basis of all this is AI, and what it does is data processing, suitable algorithm, training of algorithm, models. So when we inject whatever contrast or whatever device we apply, what it actually does, it goes through these steps, and it creates a model, and through installable programs, it gives you some images in the screen. So what we really, I'll tell you what is the difference between the liver surgery and other surgery with respect to any image guided surgeries. What in all image guided surgery, we are looking for the margin of structures. Okay, so let us say in esophagus or rectum, the basic tissue difference between these structures are very minimal. We are working on in less than 50 H unit, but in liver we have a huge advantage where in arteries you get 200 plus H units, and the liver parenchyma you get less than 50. So in real time, that is why the ICG imaging is not so much advanced in the area of proper liver surgery. It is advanced in terms of biliary surgery. When the proper liver surgery, it is more advanced, not advanced because you have other methods to detect the difference. Let us say the enhancement difference with the hepatic vein and liver is almost in terms of 100 HU units, okay, which you don't get in other organs. That's why we are more into image guided navigation. So we have intra ultrasound, ICG fluorescence, also augmented reality. But what is going to come in real future is the augmented reality. The proper liver surgery, the augmented reality is going to take over the other two techniques. So Pathfinder system, we are aware that. So what is going to happen is these sort of complex systems, you have all sort of dyes and technicalities, ultrasound incorporated into single systems. So as the previous panelist mentioned, this is going to be one of the tools for liver surgery, the segmentectomies or sectorectomies. So this is what is going to come in the future. You can see that the probe is supplied. You can imagine that laparoscopy probe is supplied. You can actually see, so this contrast difference between the structures, you are not going to create through the proper dyes and also. So this is one of our simulators where we train the students. So this is what is going to come in the intra. So what we need is a comprehensive tool, better visualization of already detect lesion, finding. This is what we need in the whether you use fluorescence imaging or any other imaging with respect to liver. That's what we need actually. So what are the applications are lobectomy, sectorectomy, segmentectomies, and visualize the bile ducts and vessels. This I am not covering specifically because it's already covered before. But what we are more interested in the visualization of the tumor. Okay. The other two are probably the simplest techniques of segmental delineation. And after my presentation, Dr. Bala will show you another video about the ICG application. So all these things, whatever the techniques, we can be incorporated into tumor ablation system, robotic system, laparoscopic system, and instrument system. So what is really going to come, as I mentioned before, is these things are going to come into the instrument system. For example, you have a laparoscopy instrument in your hand. These AI technologies are going to be incorporated into the handle of the system, and you need not depend on larger machines. So these are some of the works we done with respect to the aggressiveness of tumor, where it is, you can see that when you have the CT images in real time, this is what actually the tumor shows inside. So these properties are the properties which are going to be used by any what you say enhancement techniques, whether it is ICG, any techniques. These are the properties of the tumor which is going to be. So you can see that there are three areas in the tumor. What we call young adult and senile areas. So these sort of areas identification by various techniques will help you to prognosticate the lesion. So it looks all three are same, but finally at the end of the day, both all tumors are different. So as Dr. Kale was mentioned before, what we need in this all these is the quantitative parameter. What we are seeing especially from the imaging platforms and the crude method. That's why we finally end up in complete subjective interpretation of all this information. That's why the real data is not coming, because the mathematical quantification of what we are seeing is really lacking. So when we analyze our experience in liver tumors with this, what we really get is you can actually create a mathematical quantification of these models and tell us that what is the aggressiveness, tumor aggressiveness, you can really predict the tumor aggressiveness. So you can see that the ROC curves are going into totally on the left side, which are high predictability, and you have real cutoff value. So these values can be used for its own, and you can really predict the aggressive areas within the tumor itself. So it can predict tumor biology, margin accuracy also it can increase. So wider, more aggressive. So let us say you have extensive colorectal metastasis in both lobes of the liver. Which side you have to do a segmentectomy and which side you have to do tumor excision. These sort of applications can be used.
Second problem is we don't have fully automated, whether we use Miriam or not, we don't have fully automated image. So these sort of segmentation outcome when we tried in our images, it can be really done, and this can be applied intraop also. So this is what in the beginning I was telling, that ICG one of the tools for us. So when we have these sort of images when we created, because these are all our created images, so these can be even these sort of programs can be installed in intraop ultrasound machines and also can be used in future. So another major advantage is when we talk about a contrast. When we try to looking one step behind this sort of imaging, what we need to identify the plain images also create a lot of data basically, but we are not able to replicate it in intraop or other things. So when we tried what is happening in the plain CT images also, you can reasonably create similar images with the plain CT also with a lot of algorithm application. So it can be done in abscess, hemangioma, cyst, whichever situation it is. So you are actually acquiring the data, but because of the limitations in your technology, you are not able to produce in the operative field or other areas. So I'll just stop it here, and I request Dr. Bala. Shall I play the video here? And Dr. Bala will just talk with respect to the video. This LT Donna. Yeah.
So we use ICG in two situations. Basically, first is for demarcation. So you just saw that artery and portal vein were clamped. So before we use ICG, we just roughly mark as per the demarcation, as per the color change. And just to reconfirm, now you can see the ICG. Here in this case, it really corresponds to the previous marking. But this is very useful. We would rather follow this marking, this ICG marking, rather than the marking we use for we get by clamping. So this is the first scenario. The second one is for bile duct transection. So what we do is initially we give at 5 mg per kg, 5 mg dose at the time of demarcation. Now initially about a year and a half or 2 years back, we used to take a lot of time for the liver transection. It used to be 4 to 6 hours. So what we realized was when we were about to do the biliary transection, the bile ducts were not very clear at that time. So those days we used to repeat the dose a couple of hours later. So now we actually finish in roughly about an hour. So we get the biliary system quite well. Can we just show the second? Yeah. So this is transecting the caudate, now looping the bile duct. So that's the bile duct which has been looped. You can see the right and left ducts, and we use this for transection. You saw the clips have been applied. We're looking at the ICG and then looking at the biliary anatomy. Through that we actually do the transection. The advantage of this is we almost get a fresh pedicle, and when you do that, actually if you're not using that, a lot of times you end up getting 2 ducts instead of a single duct. So you can get a very good duct when you use this. In fact, our biliary leak rates have come down significantly since we started laparoscopic donor hepatectomy.
Yeah. So
another use theoretically is while doing transection, if you are not sure whether it's a pedicle or a blood vessel, it might help. Now, the functional liver status post-transplant can also be actually, you can detect whether graft dysfunction can be picked up by ICG, but this is all theoretical. Not many studies are actually available.
Yeah, with respect to the discussion, I wanted to ask you 2 things. How often you actually rely on a practical sense? Do you really need it every day, or is it just an accessory?
Just talking about the parenchymal transaction part only.
For parenchymal transaction, I would say we have not used it.
Not used. Okay.
It's basically theory. And with experience, actually, you don't need it.
So I also want to ask the same question to Dr. Rajan sir. So in the parenchymal transaction front, what is your general opinion, sir? Do we need a fluorescence dye or a
if you're going by the conventional method, after blocking the vessels and making the area of discrimination very clear, it works pretty well. But if you super add the immunofluorescence onto that, ICG levels are also tested at the same time, and you see that line of discrimination, if it is corresponding with the ICG, results are fantastic. There is least bleeding, very rapid resection, and you hardly have any complication.
Sir, but the problem sometimes we find it, these lines are not coordinating. That you might have.
No, we have had another problem.
Yeah.
We have had another problem wherein we found the vessels, we occluded them, and then we found the line of demarcation. But when we gave ICG, the whole thing was lit up again. Now, where was that accessory vessel? There was something which was feeling the excluded segment. We couldn't find it till the end. There was a major artery crossing inside the liver, which was feeding it, couldn't have got it extrahepatically anyway. The patient did well, okay, but that was a very confusing situation that you are giving ICG and now you are looking for what? The right lobe should not have been lit up at all. We have taken care of the rest of the portal vein and the artery. Why is it lighting up?
Yeah, so this is what exactly the problem I wanted to tell you. In liver surgery compared to other surgery, we have a problem of midplane of portal vein in the Cantilese plane, midplane of artery somewhat to the left. Yeah, accessory artery perfusion everywhere, and the bile duct and parenchymal perfusion at different plane. That's what I want the exact comment regarding that. So, Shastri sir, anything with respect to that? So
Yeah,
this is different. This is a different organ. Yeah.
Yeah, I think we should remember that it is just another tool, and definitely a useful tool because of its simplicity. You don't have to learn new things, like an ultrasound, an operative ultrasound. You need to have an idea of how an ultrasound picture looks like. You don't have a radiation. It's a simple technique. So, as we have seen in all the applications so far since morning, we have seen how this technique has not necessarily has been useful, but how it highlighted tissues. I think that is the best knowledge we have now, and rest of the things are going to evolve. What I find the best use is, of course, the biliary, the previous place where it seems to have a definite role. And as far as liver is concerned, I do not know how much it would be useful for identifying small tumors. See, there is a lot of literature on how it would identify a small nodule, which normally you would feel or do with an laparoscopic or open ultrasound, operative ultrasound. One, that, and of course, again, back to the biliary system while doing liver surgery. The biliary leaks or the adequacy of biliary anastomosis. I think these are the areas, potential areas where it is useful. Resection lines, tumor identification, functional status. I think these are things which are evolving in combination with, we have PET with fluorescence and many other evolving techniques, which would probably will see them more and more in future. But at the moment, I think these are the basic areas where it will be useful.
Yeah, Doctor. I want to make another comment here. This technology is very good, but for those of us who are thinking of using it in acute bile duct injuries, I have a lesson to share. There was a surgeon doing a laparoscopic cholecystectomy in which there was a cystic duct injury and there was bile coming in the field. They went ahead and placed sutures, sutured it up, bile was still flowing. And after that, they wanted to try a direct puncture cholangiogram using ICG, and the whole thing was a big mess. No structural delineation worthwhile was possible to identify where from is the leak coming. It was all flooded up. So this is not very limited experience, of course. I've seen it. So I would not recommend this in trying that setting. And number two, for the purpose of testing security of the anastomosis, we have already defined a very safe technique with absolute results of using air insufflation with occlusion to certify that there is no leak in the anastomosis. It's already been published 3-4 years ago in Journal of the American College of Surgeons, and now we have published a wide series of that. So that's not where ICG would play a big role.
Yeah, Dr. Bala, I just wanted to ask you one. Come to the segmentectomy and non-anatomical resection, injecting the dye into the portal vein and delineating or otherwise. How often do you use it, and what is the practicality?
We have used it only twice.
I mean, we have not used it yet. To be
Why?
frank.
Why? What is preventing you? Or
Yes,
what exactly you use it?
You need to get the radiologist in picture, and it has to be a combined thing. Yes, it definitely is likely to be useful, especially when you are using it laparoscopically. And another function which I think you have not mentioned is if there is a tumor in a cirrhotic patient and you want to do a non-anatomic limited resection, then you can actually give ICG a day prior and then take it for surgery. Under ICG guidance, you can actually do a very limited resection. That is a very useful field in cirrhotics. But what you are saying, yes, this segmental resections, yes, it needs a radiologist and you need to really plan it. Yes, it can be done. But we in India, I doubt it whether anyone is actually doing it.
Although, but the data regarding the tumor and ICG, it's showing a very ambiguous result. So your injection at 14 days before, injection at 7 days, you had a 1 day before also. But it, sometimes some reports are there where it is not even, it is masking the margins also. So I think we have to be a little bit cautious. That's what my take. Any other, sir, any other comments about the tumor and the ICG part?
The ICG is supposed to be helpful in that situation. If you give it long enough before surgery, it identifies the tumor, it holds it up, right? And you are able to clearly make out the margins, which is otherwise difficult in the absence of a hepatic vein in that area. The only limitation becomes that since you do not have a defined hepatic vein in that area, where do you draw line and margin? So if you have a tumor which is completely opacified by the ICG contrast, it will be easier to resect.
Yeah, so the timing of injection is in the tumor side, it is still not validated. That's what we understand.
That is an open question.
If no other pressing points, can we wind up, sir? Thank you very much.
Thank you so much, sir. This is not mine, sir. We'll be proceeding towards the tea break now, which will be there just outside this auditorium. And the time for this tea break is 10 minutes. After that, there will be a launch of the Viscera Elite 3 from Olympus at 4:15 p.m.
I'm more interested in going to Florence. अरे एक बात बता यार
Demo. Landscape.
Good afternoon, everyone. First of all, I would like to thank Dr. Rao sir, AIG Hospital, and all eminent faculties. Thank you for giving this opportunity to allow us to launch our latest innovative platform, that is Visera Elite 3. I'll just take you a very quick presentation of the all features which already you have been seeing since morning. Has been demonstrated. So Visera Elite 3 platform has very unique features called one of the feature is continuous autofocus and EDOF feature. So this with this feature, the image remains consistently focused throughout your surgery, even in this 2D visualization, and you get extra depth of field. So even in narrow cavities, the extended depth of field gives a very clear view of the further areas. And this camera head is autoclavable camera head with the ICG compatibility. Another feature is full color ICG, where you can see white light and ICG both on the same image. Apart from that, we have a feature called to increase or decrease the intensity of ICG, the low, medium and high levels, depending on your need. Apart from full color ICG, we also have other modes called magenta plus IR, as well as the IR only mode, which is usually helpful in the liver resections, and you can use it depending on your requirement. Another very unique mode is a yellow enhancement mode, which is being demonstrated very nicely since morning. So there are a lot of there's a newer technology which is there, and there's a lot of clinical things which are to be upcoming in the near future with this technology. Apart from this, the same platform is also compatible with the 3D imaging. So we have a flexible and rigid 3D system which is compatible with the same processor. So you don't need to have separate processor for your 3D imagings also. And it's compatible with the existing camera heads, high definition camera heads, and the 3D camera heads, and any newer camera heads in the future. So the main concept of Visera Elite 3, we said future of surgical visualization, because earlier we had three different towers like HD tower, 3D tower, 4K tower. But now with this Visera Elite 3, we have one single platform with this 4K, IR, 3D, everything can be done on a single processor with the capability to upgrade in near future with the scalable softwares. And just to give a glimpse what type of technology is coming in the near future is we have a new Endo-Eye 3D, which is a 3D 4K ICG all in one scope. Then we have Ultra Endo-Eye, Open IR extensions, molecular imaging, AI, and similar future technologies. So these all technologies can be upgraded on the same platform with the help of the software. That's why it's called as a Visera Elite 3 platform. It's not a system. It's for a system which is more than a decade. It's not one-time investment. So with Visera Elite 3, you have more sustainable investment and the future secured visualization techniques in surgical. So overall, just to conclude, it's one platform for all specialties. It's an advanced surgical platform and a future-proof platform. Thank you very much. And now I request Rao sir to take over this.
Photograph of all the faculty members. So if all the faculty members can please come onto the stage, actually we'll be very grateful, and then we just take one group photograph here. At the same time, actually, we would request the senior most member of this faculty, Dr. Surendran, to officially launch the system here, and we'll take a group photograph of. Thank you so much for launching this. Actually, at the same time, actually, there has been a lot of buzz about this fluorescein guided surgery across the globe. And in fact, there is an International Society of Fluorescein Guided Surgery. We have been in talks with those people, and they were very keen that we start an Indian association of this before anybody starts this. So we take this opportunity to launch the Indian Association of Fluorescein Guided Surgery period. And I also take pleasure, actually, after talking to all the senior faculties of the association here, we feel Dr. Surendran should lead the entire society for the time being till we have elections for this. Dr. Pradeep will act as the secretary of this, and Dr. Where is he? These two people. And Dr. Sanjeev Haribhakti will act as the joint secretary for the time being till we start the actual proceedings of this meeting in future. Thank you so much once again.
Hello. Good evening, everyone, and congratulations on this opening of Indian chapter of fluorescence guided surgery. So now there will be a speech, there will be a presentation by Dr. Ishizawa on the edge of fluorescence guided surgery with neuroimaging technology, which would be an Asia Pacific chapter symposium. So to moderate this speech, the presentation, I would like to invite Dr. R. Surendran and Dr. Adarsh Chaudhary, sir. It will be an online presentation.
Hi everyone. Professor, thank you very much for your invitation to this very valuable meeting. My name is Dr. Takeaki Ishizawa, and today I'd like to present the edge of fluorescence-guided surgery with near-infrared light imaging. So please start my video. Can you hear me?
Oh, we can hear you well. Can you hear us?
Oh.
If you can give me a 1 minute break, I'd like to introduce you to the audience.
Oh, okay, please.
Allowed? Thank you very much. So it's a great pleasure for us to introduce Dr. Ishizawa, who works in the Graduate School of Medicine, the University of Tokyo, Japan. He works in the Department of HPB Surgery and is currently the president of the International Society for Fluorescence Guided Surgery, Asia Pacific Chapter. Dr. Ishizawa, it's a great pleasure having you with us. Please, you can start.
Me too. Thank you very much for your introduction. So let's play the video. Thank you, Professor Rao, for offering me this opportunity to present cutting-edge technologies for intraoperative fluorescence imaging. This is a disclosure slide. Recently, intraoperative fluorescence imaging techniques have become used for assessing organ perfusion and identifying anatomic structures, cancer tissues, and sentinel lymph nodes in a variety of surgical fields. In the field of hepatobiliary and pancreatic surgery, ICG fluorescence imaging is mainly used based on the fact that protein-bound ICG emits fluorescence signals under illumination by near-infrared light, and also that ICG can be excreted into bile after intravenous injection. In our surgical procedures, ICG fluorescence imaging can be used for visualization of the bile duct, so-called fluorescence cholangiography, tumor localization, hepatic segmentation, and assessment of blood perfusion. Fluorescence images of the extrahepatic bile duct can be identified by near-infrared fluorescence imaging following injection of ICG solution directly into the biliary system, or by intravenous injection of ICG, because ICG is excreted into the bile from a couple of minutes after the systemic administration. In 2008, I actually applied fluorescence cholangiography by IV ICG using a prototype near-infrared light camera system in a clinical case of LabCore, in which the conference of the cystic duct into common bile duct was successfully identified by fluorescence imaging prior to dissection of Carrot's triangle. After that, our group and a lot of surgeons worldwide have demonstrated technical details and success rate of fluorescence cholangiography during LabCore in prospective studies and also by RCTs. Fluorescence cholangiography can also be used for major hepatectomies. For example, in this case of robot-assisted left hepatectomy, here we can see the anatomy of the bile ducts running on the hilar plate. Here we can see the conference between the B4 and B2 plus 3 branch. And also this is the bile duct draining the Spigelian lobe to be preserved in this procedure. So we first encircled and dissect the B4 branch. After confirmation of the conference between the right and left hepatic ducts, and after that the B2 plus 3 branch is encircled, preserving the conference of the B1 Spigelian lobe branch. Finally, B2 plus 3 branch is safely ligated and divided, preserving the drainage of the Spigelian lobe. I have also applied ICG fluorescence imaging to identification of liver tumors, but it was a kind of a byproduct of fluorescence cholangiography. One day, when I used fluorescence cholangiography during hepatectomy, I found that a nodule of hepatocellular carcinoma emitted fluorescence signals from before administration of ICG for cholangiography. I couldn't understand this phenomenon at first, but after experiencing similar cases, I started thinking that fluorescence imaging visualized the tumor probably because there existed accumulation of the ICG that had been injected a couple of days before surgery for liver function test. Because in Japan, almost all patients undergo systemic injection of ICG for calculation of ICG retention rate, which had been used as a routine liver function test. In fact, on the cut surfaces of resected specimens, fluorescence signals of ICG were identified in cancerous tissues of well or moderately differentiated hepatocellular carcinoma. In contrast, in poorly differentiated hepatocellular carcinoma and colorectal liver mets, the cancerous tissues were negative for fluorescence, but ring-like fluorescence signals could be observed in hepatic parenchyma surrounding the tumor. I have no time for explaining mechanistic background of this phenomenon today, but anyway, regardless of the fluorescence patterns, we can use fluorescence imaging for intraoperative identification of primary and metastatic liver tumors if ICG was injected intravenously within a couple of weeks before surgery. We have used ICG at a dose of 0.5 mg per patient body weight for preoperative liver function test and also for tumor identification. For example, in this case of open hepatectomy for HCC, a lot of intrahepatic metastases are visualized by fluorescence imaging. The major advantage of tumor identification by fluorescence imaging is high feasibility and sensitivity. Although this technique has limitations in relatively high false positive rate and limited tissue permeability, I believe that it is still useful in laparoscopic surgery in which surgeons cannot palpate the tumor during hepatectomy procedures. For example, in this case, surgeons could not identify the tiny metastatic tumor even with the use of contrast-enhanced ultrasound because preoperative chemotherapy was really effective beyond expectation. Even in such situation, fluorescence imaging could navigate the location through biliary stasis around the tumor, and the use of fusion fluorescence imaging facilitates surgeons to remove this region with minimum wedge recession of hepatic parenchyma. This is another case of robot-assisted hepatectomy for hepatocellular carcinoma located in segment 8. Firefly imaging is useful for set the hepatic transection lines on hepatic surfaces. And because the liver function of this patient was really poor, so only we can do was just to enucleate this tumor. And during hepatic transection, Firefly imaging works to identify the exact location of the tumor. And with the use of Firefly imaging, the enucleation was successfully completed. This is the cut surfaces of the resected specimen, and surgical margin was negative for cancer. This slide summarizes outcomes of our 65 laparoscopic hepatectomies with the use of fusion fluorescence imaging. In this series, tumor detection rate by fluorescence imaging was 87%, and 4 out of 71 malignant tumors were identified only by ICG fluorescence imaging. Hepatic segmentation is an essential technique for liver surgeons to complete anatomic hepatectomy accurately, increasing cancer curability and also minimizing risk of bile leak and ischemia of the remnant liver. In 2008, Professor Aoki in Japan first reported a use of ICG fluorescence imaging for hepatic segmentation in open surgery. And later in 2012, I and Professor Gaye in Paris established strategy of using fluorescence imaging for hepatic segmentation in the setting of laparoscopic hepatectomy using a term positive and negative staining technique. In the positive staining technique, ICG solution is injected directly into the portal branch under ultrasound guidance. Although this technique is technically demanding, especially in the setting of laparoscopic surgery, the procedure can be completed by using a long needle to puncture the target portal branch from outside of the patient's abdominal cavity. And following portal injection of ICG solution, fluorescence imaging clearly visualizes boundaries of the corresponding hepatic segments. When the root of the target portal pedicle is accessible, we can use the negative staining technique easier than the positive staining technique. For example, in this case of segment 3, the branch of Grisonian C3 is closed with a vascular clamp, and ICG is injected intravenously. Then here we can see the clear demarcation between the segment 2 with good blood perfusion and ischemic regions of the segment 3. This is the other side of the liver. The major advantage of fluorescence imaging is that we can use this kind of imaging techniques not only from the hepatic surfaces but also during hepatic transection to complete accurate anatomic intersegmental planes. And the landmark hepatic vein appears on the raw surfaces. And finally, the root of G3 is divided with the stapler. For the perfusion assessment by fluorescence imaging, we only need bolus intravenous injection of ICG and observation with a near-infrared camera system. The technique is really simple. One of the best indications of this technique would be pancreatectomies requiring concomitant vascular dissections and reconstructions. For example, in the case of modified DP CAR, we have to confirm arterial flows in the hepatic arteries from GDA and also perfusion in the left gastric artery. In this case, the common hepatic artery and the celiac artery are closed with a vascular clamp, and 2.5 mg of ICG is injected intravenously. Then, here we can see the sufficient arterial blood flows coming from GDA to the proper hepatic artery, and also here we can see the good flows in the left gastric artery. Then the arteries can be divided at this level, and this figure shows the state after the modified DP CAR. From now on, I'd like to show you a kind of destination of hepatobiliary and pancreatic surgery with the use of ICG fluorescence imaging enabled by the latest imaging technology. As you know, fluorescence-guided surgery has become common with the development of laparoscopic imaging devices because quality of full-color images and fluorescence images is a critical factor for surgeons to complete safe surgery, and the quality can vary among the imaging systems. I think that the current needs of surgeons for laparoscopic imaging system would be 4K, NIR, and or 3D imaging. And recently, we have finally had the imaging systems that meet all the three major needs of surgeons. Especially the latest Olympus imaging system named Visera Elite 3 is created based on this all-in-one concept, and with this system, surgeons can select the three imaging modes for fluorescence imaging according to the applications and condition of surgery, with adjusting intensity of fluorescence signals. The extended depth of field as well as continuous autofocus would also help surgeons to always obtain clear 4K images throughout surgical procedures without meticulous focus adjustment. Then let's see some clinical cases. The first case is laparoscopic wedge resection for HCC adjacent to the right hepatic vein. The fusion fluorescence imaging mode of Visera Elite 3 is really effective to identify the subcapsular tumor. Enabling surgeons to set the hepatic transection lines on hepatic surfaces, and the right hepatic vein is exposed on low surfaces of the liver, assuring the surgical margins. And for this purpose, fluorescence imaging is very useful to confirm the location of the tumor. And we can use fluorescence imaging frequently when we need this kind of imaging, only with the use of the switches put on the camera head. And the small vessels are divided with this device to expose the right hepatic vein longitudinally. And fluorescence imaging is used again to confirm the surgical margins. And this is the state after the specimen is almost removed. This is the fluorescence imaging. Then this is the cut surfaces of the resected specimens. And I'd like to show you how we can change the imaging modes. This is the monochromatic mode and the fusion fluorescence mode. In this case, ICG is also injected intraoperatively to confirm the perfusion of hepatic parenchyma surrounding the area of the wedge resection. And here we can confirm the good perfusion, including the segment 7 areas. And when we inject ICG intraoperatively, we can use fluorescence imaging to detect the bile leaks on the low surfaces of the liver. In this case, we can see the fluorescing spots suggesting the minor bile leak. And I think that this kind of minor leaks are difficult to identify by conventional white light color imaging. And in this case, fluorescence imaging enables surgeons to put additional sutures on the stump of the corresponding Grisonian cyst. And fluorescence imaging is used again to confirm the closure of the bile leak. The second case is laparoscopic anatomic resection of segment 8 using positive staining technique. In this case, P8 branch is punctured and ICG solution is injected to confirm the boundaries of segment 8. I mixed blue dye into ICG solution so the boundaries can be identified at the bluely colored area with color imaging, but I think that, and everyone agrees that the fluorescence imaging would be clearer than the conventional white light color imaging. This is the lateral side of segment 8. This is another color mode of viscera elite 3. And hepatic parenchyma is transected. And during the hepatic transection, ICG fluorescent imaging can be used to confirm the accurate intersegmental planes, exposing the right hepatic vein on the raw surfaces of the liver. So usually the intersegmental planes is not straight, so sometimes the fluorescence imaging is really useful to confirm the actual intersegmental demarcation. This is state after segmentectomy 8, and I think that you can feel the clear focus from in front of the views and to the deeper aspects. In this case, I'd like to show you negative staining technique used for right lateral sectorectomy. For negative staining technique, ICG is injected intravenously after closure of the inflows to these regions of the liver, and fluorescent imaging navigates surgeons to go along the accurate intersegmental planes. And in this case, the fluorescent imaging was useful to adjust the hepatic transection planes. Here, in this case of laparoscopic right hepatectomy, I'd like to show you use of fluorescent cholangiography prior to the dissection of the right hepatic duct. And right hepatic duct is encircled, and here we can see the conference. Again, prior to the dissection, fluorescence imaging is used again, and we can change the imaging mode. And here you can see the conference between the right and left hepatic duct. The last case is laparoscopic Whipple procedure. In this case, I'd like to show you the fluorescent angiography to confirm the hepatic arterial flows prior to the division of the gastroduodenal artery, and ICG is injected intraoperatively and intravenously, and here you can see the good arterial flows to the liver. And ICG fluorescence angiography may be useful to confirm the location of the inferior pancreatic duodenal arteries, although the detectability is still limited. Finally, I'd like to introduce activities of International Study Group for Fluorescent-Guided Surgery. This society was established in 2014, and recently we have created 4 regional chapters to share and disseminate accurate information for effective use of these new surgical techniques beyond boundaries of nations and surgical specialties. Our Asian Pacific chapter has been organized by board members, as you can see, Professor Rao here. And these members are coming initially from 10 regions, including India, of course. And in next month, we will have our second event in Seoul, Korea, in combination with Korean Society of Surgical Oncology. I'd like to welcome you all to this meeting and also to Osaka to share cutting-edge information on fluorescence imaging and surgical techniques of HBP with members of our department. Thank you very much for your kind attention. Thank you very much for your attention.
Can you hear me? Thank you, Professor, for the wonderful presentation. It's very lively and we appreciate it. We have been using the radio-guided surgery some time before, you know, with the nuclear medicine specialist, radio-guided surgery. How do you compare that with the image-guided surgery, the fluorescent image-guided surgery? Any idea for you?
Yeah, could you tell me again your question?
The radio-guided surgery, before the advent of this image-guided surgery, fluorescent image-guided surgery, using nuclear medicine technology. You have any
Nuclear
idea?
medicine.
Yeah.
Nuclear medicine. Yeah, I've never used nuclear. Do you mean the
Isotopes.
nuclear techniques for the detection of
isotopes.
sentinel lymph nodes in the breast surgery?
Yeah. Isotopes. Yeah.
Right?
Yeah.
Yeah. In the field of breast surgery, the best technique will be the combined use of the nuclear imaging and also near-infrared light imaging. That kind of combination can improve the detection rate. But recently, in the majority of Japanese centers, they mainly use fluorescence imaging because we don't have to handle the nuclear product. And in the field of HBB, the concept of sentinel lymph nodes has not yet been established. So the use of fluorescence imaging for the detection of lymph nodes are very limited.
Okay.
So far.
And most of the tumors you had shown were surface tumors. What will be the effect on the deeper lying secondary, the metastasis in the liver?
Yeah. I agree with you that the penetration depth is very limited.
Yes.
So in the techniques to detect liver cancer, we can detect the only the subcapsular tumor because the penetration is limited to the maximally 5 to 8 millimeters from the hepatic surfaces.
Okay.
But we can use this technique during the parenchymal transection. So in this step, the fluorescence imaging is sometimes very useful to assure the surgical margins from the low surfaces of the liver.
Okay.
And for the detection of the deeper located tumor, we can use ultrasound.
Okay.
But sometimes it's very difficult to detect subcapsular small tumors by ultrasound.
Thank you.
I have a question for you.
Yes.
Roughly what percentage of centers in Japan must be using fluorescence guided surgery in HPB surgery? A rough
Must
idea.
be. It depends on the availability of near-infrared light system, but roughly, I think that recently, the more than 60% or 70% of liver surgeons are using this kind of near-infrared light techniques.
Do you think that the benefit of fluorescence guided surgery is academic, or has it translated into clinical results?
No, I think that this technique is beneficial to patients in the basis of the clinical practice. But in fact, the use of ICG is still limited only to the perfusion assessment and visualization of the hepatic segment. So if we want to use ICG for cholangiography, we need a platform for the research. So this is the big problem in Japan.
Is there any question from the audience? There is no question from the audience, Dr. Ishizawa. It's a great pleasure listening to you. We absolutely enjoyed your talk, and thank you so much for your effort for talking to us. Thank you very much.
Congratulations on the success of this meeting. Thank you. Bye-bye.
Thank you once again, Dr. Ishizawa, and thank you to the panel and the esteemed consultants. So we'll be moving on with our next presentation, which will be by Dr. Shailesh Srikhande sir, and it would be fluorescence guided surgery in pancreatic surgery. To panel this presentation, I would like to invite Dr. H. Ramesh sir, Dr. Senthil Nathan, and Dr. Rajesh Gupta.
Dr. Ramesh Senthil. So the brief given to me is to discuss about pancreatic surgery. The first disclaimer is that I'm not using fluorescence as yet as a routine. That's a disclaimer, but I've done the homework as regards what can be done. It is being used by my colorectal colleague, Dr. Avnish Saklani in my department, but we are not as yet routinely using it. A little bit in gallbladder and liver, but we've had an excellent exposition both from Sadiq as well as this talk from Japan. So I've got 8 minutes and I think it would be good to have the discussion as well with my esteemed panelists. So straight away, let's look at what are the possibilities if we were to look at ICG in pancreas. A highly vascular organ, we all know that. Pancreatic tumors, especially pancreatic ductal adenocarcinoma, grows in a hypoxic environment, in an environment with poor vascularity. So except neuroendocrine tumors, you perhaps have a role in understanding that it can help you to delineate or differentiate between tumor and normal pancreas, because there is a strong contrast between healthy pancreatic tissue and the tumor, and this gets highlighted on the ICG. You can have a real-time demonstration, and then you can also for low-grade tumors. Thanks to better diagnostics and awareness, you know that we get to see far more solid papillary epithelial neoplasms, mucinous cystic neoplasms, other smaller sized tumors, IPMNs, etc. And you might be able to, I always use the word might because the available evidence in the literature or documented prospective experience is generally speaking not really there in a very big way, despite its increasing acceptance and use all over the world. So you can see that we have a situation where there is usefulness of ICG imaging for a neuroendocrine tumor as well. And this has been demonstrated in one of the studies which has looked at 23 cases, 100% sensitivity for net localization, 99% for cystic neoplasms. But when it comes to PDAC, pancreatic ductal adenocarcinoma, it goes down. So there is some evidence that for the low grade ones, it might enable you to do that or highlight the tumor well. I think in laparoscopic and open surgery, you also have the advantage of a tactile feel, but in robotic surgery, you don't have that. So sometimes it might be an advantage to be able to delineate it well in such kinds of lesions which are very amenable to the minimal access technique, and then you might have an added advantage of fluorescence guiding localization. This is another report which talks about perfusion guided resection of distal pancreas in solid papillary epithelial neoplasms. And that's another way of showing you neuroendocrine, cystic lesions, spens, etc. What about stump vascularity? You can have, I believe that there was a nice workshop today morning. I wasn't there, but stump vascularity, you can have a good intraoperative visualization of vascularity of pancreatic stump. I would like to be a little bit controversial and say that Stephen Strasberg, a profound thinker, some very original work from him, but he's the only one who has actually raised the issue about ischemia in the pancreas and even published a well-cited paper in JSES in 2002 on the pancreas cutback, which resulted in better vascularity and reduced pancreas anastomosis leak rates. We have a fair bit of experience in pancreas, so as all of you here, and I don't know how many of you truly believe that you run into many situations where there is an ischemia of the pancreatic remnant. Well, I don't know. So that's something which I leave it for discussion when we come to the panel. The other bit it says is that you can perhaps delineate your anastomosis or your stapled end better to know whether it is leaking or not. And this is also something which we will discuss with our experts. After you show that there is a problem, what can we really do to solve that problem remains another problem. So we will discuss this as well. And then comes the last issue of margin status. As oncologists, as well as with better pathology, we need to really understand how much is ICG going to guide us? It might help us in some, but again, the word is might and may. So stump vascularity, you can see that that's the margin. We know that there is this entity which I have been kind of, I've led the ISGPS position statement on post-operative acute pancreatitis, which is stump pancreatitis which evolves during the course of surgery. And we all encounter every once in a while in the middle of a Whipple operation that the pancreatic neck, despite transection, is not looking as nice as we would normally like. And we don't know whether there are cellular processes or inflammatory reactions happening. And that's responsible for a degree of ischemia with higher complication rates when we do. So does it help us to predict which are the high risk pancreases or the possibility of pancreatic fistula, especially in laparoscopic surgery, but I would say even in open surgery and robotic surgery as well. So yes, it is sensitive to detect perfusion defects. That's also what we know. The other bit, we saw a little bit of video. We have now crossed more than 100 minimal access pancreatic Whipple resections, with more than 80 of them being robotic. But yes, it can help us sometimes in delineating, but again, the level of evidence is not very good that you can delineate your uncinate process well and you can get a better margin. To me, again, every pancreatic surgeon worth his or her salt is going to discuss with me about identity of the SMA and the SMV and our ability to go ahead with a good resection. And we also know that our margins are actually microscopic margins. But nevertheless, you have some data, 37 lap Whipples, 10 of them underwent ICG guided surgery. All of them ended up with R0 resections. Retrospective, small group, we can have patient selection, we can have bias, and I'm not criticizing it, but just telling you that the quality of evidence is not very high. Can I get some water, please? So the last bit is delineation of biliary anatomy in pancreatic surgery. You can actually visualize the anatomical structures as well as the bile duct, reduce the chance of injuries, and do more safe resections. I'm going to discuss this also with Dr. Ramesh soon after this talk. That's because you have in this case, a duodenum preserving pancreatic head resection. A number of these, you end up opening the common bile duct intentionally, but there are situations where you may not do that. Thank you. Where you may not do that. And perhaps this is another situation where it is showing you that it's delineating, it's highlighting your area of the common bile duct. Similar to this, I can also add the non-dilated common bile ducts, and you are doing a subtotal pancreatectomy or a tumor, which is more to the neck body junction, and you divide it not anterior to the vein, but almost to the right of the vein. You potentially do come close to the common bile duct. Maybe that's another situation where we would be happier to use something like ICG to delineate it. No, I'm good. Thank you. So 25 cases of lap DPPHR, no conversion. Real-time ICG imaging was useful to facilitate the identification and prevention of biliary injury. But again, looking at it through a scientific mindset, we don't know the denominator, we don't know the experience of the surgeon, we don't know what has happened before when he or she has done hundreds of DPPHR in the pre-ICG era. But yes, there is some evidence and the pictures are nice. It clearly tells you where you are, like we saw the thoracic duct with Dr. Rohit showing it during the course of his lecture. So yes, you have tumor specific fluorescence guided surgery. So this is something which is going to come in the future. Futuristic, quite novel, that they have used a fluorescent labeled antibody, in this case panitumumab, and it's safe and feasible in a phase 1 trial. It obviously goes to the tumor and to the lymph node, and they are looking at these possibilities as well. So I think the possibilities are clearly exciting about this technology, which is going to greatly be complementary to what we have been doing it all along. You can also demonstrate a pancreatic leak from a stump. There is this video, of course, in an animal model, and what you clearly see is that you are able to visualize I suppose this is a 3-row powered, the best stapler that you want in the world. We all know that the rate of a post-operative pancreatic fistula after a left resection is about 20% in the best of hands with the best of techniques and approaches. At the end of it, you can have a situation like this and you will try to address it. I don't know whether we can really address it, but yes, the ICG does tell you, it does light up potential areas of a pancreatic stump leak. I have some thoughts at the end of this talk. This is the last slide before we go to the panel. This kind of utility of ICG, when we talk of margins, when we talk of lymph nodes, can the comfort of ICG be equated with actual frozen section examination? Maybe I can straight away start off by asking our experts their thoughts. I've presented some aspects of pancreatic surgery. Maybe Dr. Ramesh would like to make a comment or two, and the others then.
Can I have some questions from the audience first before, and we can then try and get Rajesh's and Sendil's opinions. While the questions come in, can Rajesh start off, please? Telling us, is it possible to have to identify lymph nodes outside the routine, conventional Whipple resection by doing ICG fluorescence? Do you think it's feasible? Do you think there's some data? There's a flu-panc study going on in Levine, Netherlands, which is still recruiting cases. But what do you think? I think our mic is on.
Yeah. The lymph nodes may get delineated. We may also probably know the extrapancreatic extension of these tumors. But how much will be the background activity, and are we really talking of real positive, or there may be even false positive pickups also? So that data we probably do not have, but then the possibility of pickup of the lymph node remains as in other tumors.
Do you know, Shailesh, the Nagoya study showed that a radical Whipple with an extended lymph node dissection did not give benefit.
Yeah.
And that was a huge disappointment to them personally. Maybe the truth lies between these two extremes, and this will bring it up. Would you agree?
Yeah, that's true.
I think in the post-neoadjuvant era, where we are again going back to some of the principles of Fortner, because we've got better chemotherapy in the last 10 years with better response in a selected group of patients. So we are again going back to more aggressive operations, so to say. Not all the time, but in selected cases. Maybe in those cases, it's completely right what he's saying in terms of extended lymphadenectomy. No role, all three continents, two dominant meta-analysis, absolutely no benefit of extended lymphadenectomy in pancreas cancer. Having said that, we also know that those who have responded well, have a good biomarker response, a resectable disease and good surgery, maybe ICG will come in those outliers who might yet benefit by removing that berry picking. There was a subgroup analysis by the Petrazzoli group which showed a benefit of extended lymphadenectomy, but subgroup. Again, not the best level of evidence, but some hint in the pre-chemotherapy era. Now, in the last 10 years, if I look at the same data, maybe ICG will come in as a very specific use in terms of more aggressive pancreatic surgery in good responders, and then choosing some additional lymph nodes which may come out. So yes, that's one thought.
Do you like to use ICG in all your laparoscopic fry procedures that you do currently?
At the moment, selectively.
How would you select?
What is selectively? I like this word,
I think
significantly,
it's a confusion for me,
substantially.
because everyone
What do you
is
mean
doing
by that?
Selectively, you got to inject it a fair amount of time before, remember? So when do you say you just bring out the
I'll take one question at a time. First, phrase procedure. See, it's always you see the Ramesh sir's picture that his learned hand behind the.
My friend, the question is to you, laparoscopic phrase.
Yes, that's why
that
I
story of Ramesh, I know for 20 years about the hand behind. Now you.
I want you to talk
Yes.
about ICG.
So we don't have the hand behind.
Correct.
Right?
Right.
So I have published an article where we do a modified phrase procedure where we generally don't go behind the pancreatic duct.
Right.
As far as laparoscopic phrase is concerned.
Behind the pancreatic duct or behind the bile duct?
Pancreatic duct. Pancreatic duct. So generally it's the pancreatic duct.
Just for clarification, the back end of the coring ends with the main pancreatic duct.
Yeah, but this is deep.
There is a Japanese study which has compared almost in randomized fashion that it produces good pain relief up to 5 years follow-up.
Yeah, but
no, we also published, it's again a comparative study between our laparoscopic versus open, and then our pain relief is as good as in open surgery. Uncinate is different, but posterior to the pancreatic duct, we generally don't go because we don't know the thickness. Maybe we are using more of a laparoscopic ultrasound, but not in all cases. That's what our published report says. In such situations, I'll be slightly reluctant to go very close to the pancreatoduodenal groove where the bile duct comes. Of course, we can open, suture, all those things.
So where do you see the role for ICG?
ICG, where we identify intrapancreatic bile duct. So to avoid or to delineate the bile duct within the head. That is
so. In which procedures would you do it, and which procedures would you not do it?
Okay. Whenever there is a stricture where there is a head mass, predominantly head mass, I should know how far I can go close to the pancreatic duct. I have injured pancreatic duct intraparenchymally and then sutured. We have stented postoperatively in a case, and then a laparoscopic suture to the surrounding pancreatic parenchyma I have done. But after this, probably I can be more cautious, more roadmap will be available for me to how far go towards the pancreatoduodenal.
Dr. Ramesh, anything to add irrespective of the approach?
I think I would urge all of us to inject ICG the day before or the evening before.
Okay.
When you are dealing with a prospective friar, a beggar procedure done either laparoscopically or by open surgery.
Open surgery.
It gives you the additional dimension of knowing where the bile duct is. The caveat is that unless you get a fair amount of pancreas off, from a distance, it doesn't show up. So when you get close to the bile duct, that's when if you keep using the instrument over and over again, and then you would then notice the bile duct. So it has to be a repeated use. In the laparoscopic environment, the scope is already with you. If you're going to do open surgery, the scope is usually being used in another OR for a laparoscopic procedure.
Has a question.
And it's not available. So it's a logistic issues as well, but it's worth doing on a routine basis because I think it'll give you another dimension of understanding of where your bile duct is.
Sadiq?
So just a minute.
Okay. We have 2 minutes. We have 2 minutes, boss.
First part about lymph node, that means you will have to inject into the tumor or around the tumor. So how would you would do it ultrasound guided, US guided, in order to the initial discussion about lymph node identification.
I think
that will be adding another procedure.
And for a PDAC, I'm not sure that intratumoral injection is a great idea in any event for a tumor which grows, in an environment which doesn't light up. It's not very sensitive, as I showed you.
The second thing about phrase which we are discussing, I mean, you've been doing all this while. Do we really want to see or we encounter the bile duct as so often that we now need to identify it?
But I think it definitely makes the operation more interesting.
But I think important point in open,
more precise perhaps.
This is like a BBC answer. Interesting.
No, so, in open procedure is we need to have ambient light low. And how do you, even if you see that lighted bile duct in an ambient temperature light where you are not seeing anything, how do you do dissection?
I have one more question. No, that's only for a transient time. But I have one more question.
You have to dissect.
But I have one more question for Dr. Ramesh, that yes, I think it's going to give us the sense of comfort, which is perhaps going to be a little bit more now than ever before. Having said that, before this, how commonly were you running into difficulties with your vast experience of pancreatic head masses in chronic pancreatitis vis-a-vis the bile duct?
Yeah, we've had just one catastrophe, and that is a posterior, a through and through injury to the bile duct along with the back wall of the pancreas. And it happened when Dr. Sadiq and I worked together. and late at night we had to convert to a Whipple resection.
Yeah.
And that's really the only case where we bit off more than we could chew. Otherwise, it wasn't one of those.
Others, sir?
Ramesh, I am very sad. All these years you told us that bile duct was not a problem in praise. Today we have ICG, you tell us it is to be routinely used. I didn't expect this from you.
I think you're just
No, seriously. You
begging the question. I believe that.
So we'll keep this for the evening.
Yeah.
So I think to summarize, if you were to ask me to summarize about 3 topic specific areas.
Dr. Silas,
I
sorry
think-
to interrupt.
Yeah.
Since you are coming from a predominantly an oncological background, it
Yes.
has use in benign conditions like pancreatic necrosectomy and walled off pancreatic necrosis, where especially internal drainage, where we avoid the vessels, cystogeginostomy, cystogastrostomy, where the vascularity can be better.
I disagree with you.
I disagree with you. Sorry to interrupt.
I'm sorry, but I disagree with you.
We've used it. It's such a mess. You cannot find out. It's a mess.
I've used in cystogeginostomy.
I would
where
rather say-
transmesocolic anastomosis, you can see the middle colic vessels nicely and you avoid.
Okay.
We have used laparoscopic ultrasound.
Ultrasound, yeah.
Yes, laparoscopic
Yeah.
ultrasound. But again, that's a logistic difficult. Now it's a click of a button.
Fine, just
we
give
can
an injection
identify
and
the
then
vessel.
fine.
Dr. Shailesh, can I think
Yeah.
in the tumor front, we have to be very cautious. Why it is cautious? Because the ICG needs protein binding. Okay. When you actually dissect out the tumor, what is inside the tumor, there are various differentiation and near normal functioning tumor. If you can see the previous lecture, you can see the ICG activity on both sides. Okay. This is the reality we have to see. So when you take the mechanism ICG, we should not too much extrapolate that. ICG is actually, there is a mechanism through which we can really make the ICG concentrated only in the tumor.
Yeah, that's
No,
technique.
it is
specific
not
technique.
there.
Yeah.
Okay. Especially in HCC and pancreatic tumors, you have a lot of oxidative stress and DNA damage on both sides, outside the margin also. Okay. This makes it really complicated that we cannot really predict that ICG gives us a very clear margin in the tumor. There are tumors inside the tumor also. There are near normal functioning cells. So the idea of differentiating may not work as such we predict inside tumor, and that is why the evidence is, as Dr. Shaila really pointed out, we really need the evidence that is actually differentiating.
So I'll close the session by saying that for the association and for this elite group, which you have made us believe that we are elite by getting all of us here for a nice day in Hyderabad. So the thing is that we can actually all of us do a prospective study. Let me make a suggestion to you. When it comes to pancreatic transection, pancreatic anastomosis, common bile duct delineation vis-a-vis lap or open chronic pancreatitis surgery. In the evening, I'm going to dive into both of them about going behind the duct versus not going behind the duct and documented data and the denominator versus benefits of ICG. GV Rao is smiling. So I think I've done my job and we will stop here. Thank you. Thank you.
Apologies to Dr. Avni sir for mispronouncing his name. So this was a very nice presentation, the last one, and a good discussion which might follow after this session also. So we'll be going on the next session that we have on the fluorescence guided surgery in colorectal surgery, which will be presented by Dr. Rohin Mittal sir. And to chair it, I would like to invite Dr. Deepak Govil sir, Dr. Avnish sir, Dr. Nagaraj Palankar sir.
Hi, good evening. I think this is one of the last sessions of the day on fluorescein guided imaging, and hopefully I'll share some more knowledge and probably stir some more controversy on this. So the topic is fluorescence guided colorectal surgery. Again, this has been covered again and again for uses of ICG in surgery in general, assessing perfusion, identifying anatomy, and localizing tumor. This is probably the most useful use for ICG in colorectal surgery, that is assessing tissue perfusion. We saw a beautiful demonstration this morning. The need to assess perfusion is important because of anastomotic leaks, which happen between 8 to 16% in colorectal surgery. And poor perfusion is one of the reasons for an anastomotic leak. Traditionally, we have looked at color, pulsations, and bleeding at the bowel edge, but ICG allows us, or the near infrared fluorescence allows us, a faster delineation of ischemic tissues. So by naked eye, if the bowel is ischemic, it takes about 10 minutes for the color to change, whereas in ICG, just within less than a minute, you can see the difference in perfusion. Studies have shown that if we use ICG, there's about a 10% chance of change of your initial planned dissection margin. So about 1 in 10 patients, we will change the margin of where we want to cut the colon based on the ICG. However, does this translate to a decreased leak rate? That is not known. The evidence on that is unclear. There are studies which have shown that there is no difference in leak rates, and there are studies which have shown that leak rate is slightly low, but the evidence on that is not really clear. So we may change our resection margin, but whether it actually translates to a patient outcome is still a gray zone. However, if you look at more granular data, probably there is an effect, and the effect is modest, and it is probably good in patients who are at high risk for anastomotic leak. If you use it on the run-of-the-mill patient, you might not find a difference, but if you use it on high-risk patients, you might find a difference. So here's a small video of one of our cases. Let me run it through. So this is a low anterior resection. I'm sorry, I think the video is not projecting very well, but you can see the ICG coming right up to the edge of the stapler. The green fluorescence is seen, and you can see that it is well vascularized as well. So here it's an ultra low anterior resection. The anastomosis is being done, and we will again check it with ICG. Again, both sides of the anastomosis are nice and vascular, and it's got good fluorescence. So this is the use in anastomosis. However, this is not, an absolute. We've got to be careful and use this with a few caveats. It's not perfect. Leaks still happen even if the ICG is used and it shows good fluorescence, because there are many other causes of leak apart from just perfusion. Again, one important thing is mucosal perfusion is not assessed if you look only at the serosal perfusion. What we saw in the morning was that we use the ICG camera to look from the inside, where we can use assess mucosal perfusion as well. But normally, most people do not assess mucosal perfusion. So that's something to be aware of. Again, the dosage and timing have to be accurate. Again, we saw in the morning when we used it first, the perfusion was good, but next time it didn't really take up very well. Sometimes we look at it and say, oh, is the dose not correct? Is the timing not correct? So the dosage and timing have to be spot on for us to be able to see it. And again, this has been discussed again and again. The intensity and is assessed visually. We actually need quantification to be able to make some better value. Now, I showed you a video. I'm just going to show the same patient. Unfortunately, the patient did not do very well. 4 days later, had to go back to theatre. We suspected conduit ischemia, and we did a laparoscopic re-exploration. Again, this is the same patient. You can see the conduit going down. We reassessed it with ICG. You can still see ICG being taken up right down till the anastomosis. But the colon does look a bit angry on white light. We did find a small collection, and when we did a rectal examination, found a small leak, so we had to dismantle the anastomosis. Now you look at it, it looks all good, but when we cut the specimen to try and see what happens, you can see that there's mucosal ischemia, and it's going on for quite a long time, quite a long distance, and finally we found a good mucosa about a good 15 centimeters away from the anastomosis. So this is same patient we've seen used ICG and done the anastomosis. 5 days later, we've gone back, used ICG again. The serosal perfusion is good, but the mucosal perfusion is not good. So we've got to be very careful. ICG is very useful, but there are caveats and there are pitfalls. I have shown just one of them. This is not to deter its use, but just to keep this in mind. The second use is in localization of the ureter in colorectal surgery. Again, ureteric injury occurs is rare, but it does occur, and especially in reoperative pelvic surgery. in open surgery, we advise ureteric stents. We can feel them during surgery, but in laparoscopic and robotic surgery, there is hardly any tactile feedback. What has been suggested is lighted stents, which can be seen during surgery, but again, availability is limited. And then you've got to put a ureteric stent, which is invasive and it has to be removed again. So ICG is relatively less invasive and real time and can be used as an alternative. So what we do is inject ICG into the ureter either the day before the surgery or at the time of surgery just before starting through a ureteric catheter, which can be immediately removed. Again, it's useful in complex cases and is found to be better than ureteric stents. Up to 93% of ureters can be visualized by ICG alone. However, very few case series literature is still evolving on this. This is one of the cases that we've done. This was a gentleman who had a low anterior resection and had a second tumor about 5 years later on the left colon, which had been pulled down into the pelvis. We had to go and do a completion colectomy. You can see here that the colon's being mobilized. However, there's this structure here, and we're not sure whether it's the ureter, it's the artery, what exactly is happening. We had given ICG, and here in the second image, you can see that it's nicely lighting up, confirming that this is the ureter. So in these kind of cases, it is useful. Again, a relatively rare use, but quite a useful one. Identifying localizing cancer, I don't think much use in colorectal surgery. Again, the mechanism has been discussed before and is useful in, especially in colorectal surgery. It's supposed to be useful in peritoneal metastasis, but again, literature is very rare. I've never used it before. I don't know if any of you are using it, but it's something which is very experimental at the moment. Lymphatic mapping, again, a lot of discussion about lymphatic mapping already has happened. Sentinel node mapping in colorectal surgical resections is not of much use because we remove the whole mesorectal package or the whole mesocolic package. So mapping out the sentinel lymph node might not be very useful. If the lymph node is identified beyond the standard area of resection, then perhaps it is useful. But again, this needs to be studied much more. Again, ICG is not very sensitive or specific. Again, for early tumors, it's likely to be more sensitive and specific than late tumors because if there's tumor in the nodes, it blocks the nodes and ICG does not percolate and you can get a false negative. Again, this is something which is under study. So again, those are the 4 uses. I think the biggest use is in perfusion assessment for anastomosis. And then the second is in ureteric identification. The other 2, not so much in colorectal surgery yet. So I'll stop there and we can have a discussion.
Yeah, I agree. I think the most commonly used is perfusion. We've also used it only for perfusion. We haven't used it for ureteric localization and any other sentinel lymph node mapping. But for perfusion, also the issues are, again, the quantitative assessment is very difficult because there are a lot of factors, the dose, how close the camera is, all those things really. In fact, we did a study of around 50 cases of all GI anastomosis being done. We studied and compared, we clinically identified and marked a point where we felt we should be resecting. And then with the use of ICG, there was a difference in almost 10 to 15% of patients where we were able to change a decision of resection. So that probably helped us. But otherwise, for perfusion, it is definitely gives us a sense of more satisfaction. But it is obviously, even after assessing perfusion, the chances of leak are higher. I think it's still in developing stage at the moment. And in robotics, definitely it's much more easier to use with the Firefly fluorescence available.
So Dr. Rohin, see, you mentioned about a situation wherein, you wait for ICG perfusion and you demarcate the dynamic ischemia, but you get some clinical situations wherein you are difficult dealing with a very difficult low anastomosis, and then you have a situation wherein the clinically it doesn't look bright, but the perfusion looks good on ICG. So how do you deal with those situations? What are the chances of healing? Do you have any data on that?
So I think that's a very important point you're picking up, but the data on this is really evolving. If you look at data of use of ICG versus use of no ICG, you'll hardly find trials where you've used ICG but found that ICG is not perfusing, but you'll go ahead and anastomose anyway. Every trial ethically will then go back, cut back, and then do an anastomosis to healthy bowel. How do you compare these groups of use of ICG and no use of ICG? So the only comparison that can actually happen is from retrospective data when we did not use ICG to data now where we're using ICG. So there's obviously an inherent bias in these trials. So getting true data out of it is actually quite difficult. When it comes to difficult clinical situations, I think you have to use your clinical judgment to do it. If you find that perfusion is good, but there are other features which make you feel that something is wrong, I think you have to go by your judgment. Just because the perfusion is telling you it's good, you can't say I'll ignore everything else. I think you got to take everything in mind. Like in the case that I demonstrated, the perfusion was looking good, but the patient was not doing well. There were signs of patient deterioration. Clinically, when we did a EUA, we found that there was something wrong with the anastomosis. So we decided to take it down anyway. And then we saw that there was mucosal ischemia for a long distance.
I think there's a paper from Wexner. They have identified a quadruple assessment for an anastomosis because just one ICG is not enough. So they've assessed the air leak along with endoscopic visualization also of the mucosa with the fluorescence. So all these 3 or 4 things should add to give you more confidence about them.
Yeah, so I think they look at ICG, they look at endoscopic visualization of the mucosa as well as air leak. And they found that if all 3 are negative, then their leak rate is very low.
So Rohit, these are great technologies, they are evolving. So hopefully the Visera 3 Elite is good and that should help us. So whenever we look at retrospective studies, Pillar 2 study by Wexner, the leak rate was 1.2%. That was really good. But when you did an RCT Pillar 3, then you didn't find any significant difference. So I asked Wexner himself, if the ICG and vascularity was very good for low anterior resection, would he avoid a stoma? He said that would not change his practice at all. In fact, there's another study, FLAG, which shows positive result, but the anastomotic leak rate for rectal cancer was 25% versus 14%. So it's really high in most of these 4 things. The other thing is for lymph node mapping. If the lymph node, 20% of the subcapsular area is occupied by lymph node tissue, it won't pick up. So again, for lymph node mapping, it's not really good. But I think it cannot be used for everything. But in cases where you're stuck, like if you're taking the inferior mesenteric vein and you have meandering artery there, and sometimes you can have delayed ischemia. So you can put an ICG and see whether it's going to survive or not. Or sometimes you have around while mobilizing the splenic flexure, you have damage to the hemata on the marginal artery. You're not very sure, then you can have a look. If you're trying to take down that excess colon, you may end up with a permanent stone. In those cases, but these are great technologies. I think we just have to evaluate them and get it better. And an association like this can actually help us, and all of us can get together and get great data. I agree with Shailesh. This is a time for everything in evolution. So let's get together, have good data, and make it work. I think technologies are there if we get together. What do you think, Dr.
Definitely. Can I?
Yes.
Yeah. So I mean, this is interesting because morning we saw GV's group doing the anterior dissection, and they were looking from inside also. I've never thought of looking from inside as a fluorescence with fluorescence cholangiography or angiography. So do you routinely do, or do most of us routinely do examination intraluminal for fluorescence angiography? And should it be a practice, especially what you also showed to us that there was mucosal ischemia to a great distance?
So we've been thinking about it. There are some Western centers who use white light endoscopy routinely. They have a colonoscope in theater and they use it to distend the anastomosis and do air leak as well as look at color of mucosa on both sides. I don't think an ICG endoscope is available as of yet, but we've been thinking about how to do this, and I think what we saw this morning is probably a good best way to look at it. At the end of it, put the laparoscope inside and have a look at it. I think it gives us the best of both worlds. So I think it definitely adds one more step to the operation, but it gives you a bit more comfort. The important question is, we can do all this, but does it actually translate into better patient outcomes is something which we have not established yet. And that is something that needs to be established. And also, I think we have to see a subgroup of patients where doing all this will be useful. I don't think it will be useful for everybody, but probably in high risk patients. And those are 2 things that, and how to quantify the effect. So these are things that are for future research. Yes.
With regards to your timing injection of ICG into the ureter, we have always been thinking that it should be done immediately just before the procedure starts. You said it's if you're giving 1 day prior, will there be a washout of the ICG?
Yes. So what we also do is just give it prior to the procedure, but literature says you can do it up to 2 days in advance. If you look at papers by Steve Wexner and everybody, I mean, there are only about 13 or 14 papers in this whole field, but there are people who have done it up to 2 days in advance. So what we found is it's best to give it just pre, and we keep the ureteric catheter in place. Sometimes if it washes out, we just give a second dose through the ureteric catheter and we can have a
That's
look
what
at
the
it.
point I was going to make. Even if it's a long procedure, you don't see the same intensity as it was in the beginning
Yes.
of the surgery. And
Yes.
then we try to give us a
Yes.
second
So,
shot of
towards
ICG.
about 3 or 4 hours into the procedure, if you're
Exactly.
still not there, you just give a second dose through the ureter. Yes.
And as a continuation of this, would your plan change for neoadjuvant irradiated rectum? Would you mind doing it without ileostomy, or still your plan will not change?
Again,
suppose you see a nicely perfused both the ends in an irradiated rectum. What do you say?
As of now, no, I don't think I have the courage to say just because the ICG is positive, it's looking good, I will not do a stoma. Maybe a day will come where we can probably quantify it better and take that risk, but as of now, no.
Yeah. I think we would agree. There's just one area where probably it might be helpful. Sometimes along with a rectal lesion, there is a small polyp on the right colon or something. Maybe putting rather than having an intraoperative endoscopy to localize that something a day prior, if you can inject it, maybe that will help for these small lesions which may be requiring an additional resection.
Rohin, just your comment about the ICG is not there in the endoscopy. But that's what you are trying.
No, I'm not aware. Yeah.
Basically, the reason is, see, we have to realize that the colonoscopy and endoscopy has gone to a different model. Like you put the scope, you can see narrowband image, you can see finer vessels within the tumor. You can really see vascularity inside. So what we have to realize in the practical sense, that has not it's actually we are on the negative side. Those technologies are not coming to laparoscopy. So you can imagine that a laparoscopic tip is showing the same image intra. What do we decide? What we are going to decide? The endoscopy, the narrowband imaging, exactly the perfusion. You put a colonoscopy, AI systems in the colonoscopy, all are there. So what we have to learn, they are much in a decade, the colonoscopy and endoscopy a decade ahead of this laparoscopic system. So once it comes into force, probably I think most of our discussion answers will be very, very clear. Those techniques are incorporated into our laparoscopic tip. That will really going to change. That's what probably I just want to put a comment about.
Absolutely. I think we'll close now. Thank you, everybody.
Thank you, Dr. Rohin, sir, for such a focused approach in this presentation. Now we'll be moving on towards the next presentation, which would be on newer yellow enhanced imaging, the one which we were demonstrating in the morning. This would be done by Dr. Shreyas Modak and Dr. Sanjeev Patil, sir. And the topics that would be discussed would be principles and imaging and use in hepatopancreatic biliary surgery and in colorectal surgery. So for this, the panel, I would like to invite Dr. Devendra Nayak, sir. And I will also like to invite Dr. B. Upendra Rao, sir, to the panel. And I would also invite Dr. Sanjeev Patil to join them, and Dr. Shreyas Modak, sir, to the podium. Let's start off again.
Very good evening to all. So this will be the last session of the day. So last 9 sessions the green has enjoyed a lot. So now is the last session for the yellow. So as all of us know that whether it is a human eye or the digital pixels, the basic colors are red, green and blue, and yellow is made up of red and green. So what we see, the different shades of yellow is different combinations of proportions of red and green. So there was a feedback from some surgeons to the R&D department of Olympus, and they said that they wanted to see structures like ureter, nerves, arteries, which are covered by fatty structures, fatty tissue, and they want to see them more clearly. So the R&D department from Olympus has developed a new technology called yellow enhancement, and that has been added to the Visera Elite 3 as a default function. It emphasizes the different shades or textures of yellow, and it increases the contrast between different yellow shades. So how it does? So basically it senses the digital processor in the system, senses the beta carotene and blood contents of the tissue. So normally on the left side, if you see on the white light, the tissues will appear like this. But if the beta carotene content of the tissue is very high, it will go towards the greener side. And if the blood content is high with low beta carotene, it will be on the pinkish side. So it increases the contrast. It makes us differentiate between adjacent tissues more effectively. So in a white light, a yellow tissue will appear a pale yellow, but in yellow enhancement, it will appear greener. Orangish yellow is a shade that they have described where there is a more vascularity that tissue appears like this, and in yellow enhancement, it will be more enhanced and becomes yellow. Red remains the red. So in real life, it looks like this. In white light, the picture looks like this, and in yellow enhancement, the yellow tissue is turned to the green. The pinkish tissue remains pink, and the orangish yellow that was centered ahead of the pancreas looks like yellow. So since this is a very new technology, some of you have seen in the morning the use of this technology, but most of you are unaware of how it looks like. So what we have done is we have made some semi-edited videos where we had the opportunity to experience this technology. So we will be playing these videos, and we want your valuable opinions. You can scan this QR code and give fill the Microsoft form and give the opinion, or you can join the discussion. So I will keep the panel for discussion open, and we'll start playing the videos, because there is it's not about the technical steps about the surgery. It's about how it looks like in the this yellow enhancement mode. So all the surgeries are like a comparative surgery. One is done in a white light 4K or HD, and one is done in the yellow enhancement mode. So I asked the panelists to comment.
Basically, it's a new technique and we don't have any experience upon these things. But I really want to know about that. What is the real advantage of this yellowish
That
discolor?
we also don't know. So we want your first-hand experience. After seeing it first time, what came to your mind that whether it will be useful or it will be just like a luxury?
No, we have been using it probably around 8 to 10 cases. We have operated all advanced as well as basic laparoscopic surgeries. What we found was all these videos are those which we have recorded. There is definite contrast differentiation between structures. That is for sure. Even in the morning when we were doing the low anterior resection, the blood vessels in the fat, I think, are better delineated with this. And if there is lot of fat on the ureter, probably the fat is seen so well that you can dissect out the fat from any structure like ureter. And different structures, not only the color but also the texture of the different structures appear different in different colors. So that is how you can create go in the correct plane. If you are going away from the correct plane, then probably you will be knowing easily if you are in this yellow mode. That's what I feel operating few cases in the last week.
This system also have a 3D system also.
Yes,
incorporated that. So if we use the 3D system, then what is the advantage of this yellow discoloration? In 3D, that will create a blood image of the yellowish system. If we use the 3D system along with the yellowish,
along with yellow, 3D can't be used.
Yeah,
3D is
but 3D one, yeah. But if we have the 3D system, that 3D system is better than this yellowish discoloration, yellowish enhancement. I think so.
So what I have felt is the most advantage of this technique is the differentiation between tissues is a little bit more enhanced.
And any advantage of this ICG along with this
ICG
yellow?
cannot be combined with yellow.
So,
This is just a digital processor makes the shades of yellow in a better, more contrast.
Actually, even we are not very sure about this thing, but by sheer comparison of these two images, because one is on white light, one is on yellow mode. See, basically we're trying to see it's a new, it's a filter that is introduced just to see whether it will be useful in clinical practice or not. I mean, it's got no role about the 3D and all, this has got no comparison. 3D is more about the depth of the thing that you're perceiving here. Here it is not the depth you are talking about, but here we are talking about the color enhancement actually. Morning we were able to, actually when we are doing the anterior resection and also the distal pancreatectomy, we shown some difference between, we switched between white light and yellow light just to show the difference. So over the period of time, the people who have been working on this, they feel that some advantage of working in this yellow light in some areas may not be that it is useful in all areas, but I think we just have to try it in different dissections to see whether it is really any great benefit. As in now, we cannot say that it is going to improve our outcomes, anything of that sort, but definitely I think it will increase the speed of the surgery. I think I would request the comments from the elite the faculty who are sitting here just to see whether it makes any sense using this.
Thought I was there in the morning, so we saw the surgeries, both the surgeries, and I think to me it looks like that there are two areas where this can really be useful. One was when you are dissecting very close to the vessels, so especially when you are at the root of the ileocolic or at the root of the IMA, the vascular differentiation with the fat is so enhanced that you can really do a precise dissection. I think this is the time that you can put this on, rather than just operating on this mode. If we keep operating on this mode, then our eyes get tuned to this contrast, and then we don't like to work under white light. So I think we can use this whenever we need it. The second area I saw that was in the TME plane. You could see the TME plane better because it's all, you have to get outside the fat and you have to get into the areolar plane. So that plane we could, and especially for the trainees, for the younger surgeons to do a good TME, I think this is a good mode. I think this is very, so in certain areas we can use it, rather than doing the entire surgery on this mode. That was my take on this.
Yes, sir, definitely. The vascular pedicle can completely be bared better in yellow light than in white light. Whatever fat nodes are there at the base of the vessels can be clearly taken off using this light. That is one thing. And even nodal harvest, probably as we go to the base of the vessels, all the nodes and the fat tissue can be properly delineated and taken off. That is definitely one advantage, what I feel, but it's too premature to comment that whether it really help or not, but it is for that all the panelists to use this, see, and then come out with one conclusion whether it will help or not. Yes, Sindhu.
Yeah, offbeat I have used it in a couple of occasions. One, differentiates fatty pancreas from real fat during the pancreas mobilization. The second area is a difficult adhesiolysis in a ventral hernia where the bowel has fat, the mesentery firmly stuck. So we could be able to differentiate between the bowel and the omentum clear in a nice fashion. It adds a little bit more edge and the comfort for adhesiolysis, especially in close shaves. I've used it in one case. It was really. It's my a few cases of experience with the yellow mode.
Dr. Surendran?
Comment is it really looks brighter and better. I mean, when compared to white light. That's a comment because I have not used it.
Yeah, probably once we start using to this, like for example 4K, we are now so used to 4K that HD 32-inch monitor we feel difficulty in operating because daily we keep operating on 4K. Probably this will become like that in future. If we are used to this, probably we may not be able to operate on white light is what I feel.
Yeah, the advantage here is you have both the modes. You can switch.
Yeah, you can switch. Yes, sure.
I think that's a great advantage, one. And that makes us use it selectively where you need, you switch over to yellow mode.
Wherever
otherwise, this high resolution and this brightness may be an enormous strain on the eye.
On the,
for long
correct.
surgery.
So that's what Dr. Sanjeev Varipakti sir was telling. So better to use it where it is required.
Actually, now that this is something like they have the narrowband imaging on the endoscopy side, just switching on the mode, we are switching it. So I think switching between white light and this light could be helpful rather than completely operating on this light or white light actually. Yeah, in areas of difficulty, I think we can switch over to this yellow mode, yellow light enhancement. Yeah, but we've seen actually people often they're quite comfortable using, but again, it all depends on we don't have any.
So if there are no comments, we'd like to close the session.
Yeah.
Thank you.
Thank you so much once again. Actually, at the outset, on behalf of AIG, actually, I thank all the faculty for coming in here. Thank you so much for taking off your time. Thank Olympus Sun Pharmaceuticals for their support. I really learned actually, though it's a very small group, we really learned a lot of things, actually exchanged ideas. I hope something else will crop up actually. And Shailesh is there. We're already going to start a randomized control trial. Yeah, I think we'll start that actually. We'll do that. Yeah, pilot study or random. Thank you so much. Wonderful day for us. Actually, sincere thanks from all of us, team AIG, for all the faculties who made it in time. Some housekeeping calls. Actually, we have a bus that is going from here to the resorts. We have a sit-down dinner that starts at 7:15 sharp. Basically, it's a sit-down dinner, so you understand that there is another session that starts around 9:30. So this is a sit-down dinner that starts at 7:15 p.m. sharp in the Minar restaurant in the resort. So after we go, we can just freshen up and then come to the Minar restaurant by 7:15 sharp. Thank you so much once again, and we'll see you at the dinner. And again, a sincere thanks to all the support staff here, my support staff from the AIG Hospital for their support, without whom I couldn't have done this job.